methods are less in amount, that is 4%, and the unmet need, this is what has to be focused, that is 10%. So among the whole population, if 44% are going by modern methods, 10% it has to increase, because they come under the unmet need for contraception, and there are 42% who do not need contraception. So these are some graphic representations by WHO, in which they have shown long acting and short acting. So almost half long acting and half short acting method being used, but among that female sterilization is a big one, and male condoms is a big one, and I can't see it, it is so small. Oh yes, it is so difficult here. So the female sterilization, it is 24%, and male condom users are 21%. So they are the biggest chunk, and then comes the intrauterine device users, they are 17%, and then the pill users, they are 16%, and they are smaller chunk, like 5%, they are using this alternative method, rhythm or withdrawal, 3%, 5%. So but the injectable users are only 8%. So if this increases, most of the unmet needs will be covered. So from going from these three things, like female sterilization, condoms, pills, intrauterine devices, the new focus should be on the injectables and the implants. So contraceptive use by method. Again, in this, the red ones are female sterilization by countries, by regions. We should not go into this because in our parts, of course, it is female sterilization has a big chunk, and it is shown here Eastern and Southeastern Asia and Central and Southern Asia. Both the things, in both of it is shown that in red that female sterilization has got a big role, and intrauterine device is the orange one, it has a big role, and then comes the green one, which is the pill, the light green one, and the injectable is the darker green one. So contraceptive use by method. The estimated number of women of reproductive age 15 to 49 years using various contraceptive methods from 94 to 19. So female sterilization, so from 2019 and 94. So the lighter one is 94 and the darker one is 19. So female sterilization has gone up, male sterilization has gone down, intrauterine device users have increased, implants have increased a lot, injectables have increased, and so on so forth. The pill, male condom increased a lot, rhythm method, withdrawal, it has decreased, and others, they are almost level up. So percentage share of contraceptive use for the common method among women of reproductive age. So what catches our attention is that what is happening in India, 50% or more. The darkest one is in India, 50% or more are using contraception, and the lighter orange is 30 to 50%, and the pink one is less than 30%. So in our parts, 50% or more are using contraceptives. Estimated prevalence of individual contraceptive method among the women of reproductive age, again 15 to 49 years. Female sterilization, intrauterine device, again in female sterilization you can see that India is in dark blue, so it is more than 30%. Intrauterine device, again you come and see, no, it is not in dark blue, it is in light blue. So less users of intrauterine device. We all know, because they do not accept it. We give them intrauterine device, they do not use it for a long time because of the various complications, whatever is occurring, bleeding hota hai, pain hota hai, and that is the story. So it is in the light color. So less users, 5 to 10%. Now pill. So our country is again in the light blue area. So it is either less than 5% or 5 to 10%, not more than that. So from this we know that after deliveries, they are offered contraception. Either a pill is given or intrauterine device is inserted, but it is not accepted. By and by, finally, we cannot go on with like this. They come up for female sterilization. So that is so a lot of contraception is going on in India, 50%, but they end up in sterilization because of the acceptability. Contraceptive use by method. So we have seen this graph and it is almost a revision. This is female sterilization. The biggest chunk, male condom, pills and intrauterine devices. So to end up, family planning and human rights, all individuals and couples have the right to decide freely and responsibly the number and timing of their children, and also to have the information, education and means to do so, and the right to attain the highest standard of sexual and reproductive health. So with this overview, I would like to end my talk and thank you Manipur once again, and whoever was listening, thank you again for that.
Thank you, Madam Speaker, for the illuminating talk on such an important topic. And now the topic is open for few comments and questions because of the limited time we have. Thank you, Datta sir. Thank you. Yadar
Teenage pregnancy.
Sir, you can speak from here.
No, I am very much concerned on, Madam, I am very much concerned on preventing the teenage marriage and pregnancy. And from the Indian Medical Association as a president, I am mobilizing everywhere. We cannot prevent the teenage marriage because of social problem in many states. In my West Bengal also, teenage pregnancy more high. My request to you, because I already written a letter to the health ministry, how can you prevent the teenage pregnancy up to 21 years? Because if she marries at the age of 16 or 18 years, can you keep her up to 21 years? Which contraception is better? Because it is mandatory to prevent the pregnancy before 21 years, to prevent the maternal death. Now, can you give me a suggestion? Which contraception is better for that groups? Means the girls who married before 21 years of age, even 18 years, 16 years like this. No, I will give you the mic. No. Because nobody is talking, I am talking.
I cannot really give a comprehensive answer to this, but the fact comes about the acceptability. Since the society is not accepting a delayed marriage, will that society accept a particular form of contraception? So, if you can force a contraception, you can't. So you have to explain, and I think implants can work in that. So I said everywhere that condoms are doing great, intrauterine device is doing great, female sterilization, okay, but the only thing that should go up is implant. OC pills. So OC pills, again the same thing will fall back. Is it acceptable? That is a problem. It is not acceptable. Many times when they take OC pills, then what happens is there is irregular bleeding because of the fault in taking, and that ends up in just refusing it. And by the partner, many partners even think that there is some problem with the girl. She is having some disease and all that. So the acceptability will be best if it is put as an implant. And if the government really works in that area and makes the people aware, and we work in that area, it will be good.
Where is the other?
Actually, counseling is the best part we have to do. Female education and counseling, we have to go with. And when we take time and we have a tender loving care with our patient, teenage patients, and if we can explain them about the complications of pregnancy, teenage pregnancy, and repeated childbirth, then only they will accept it, and the proper method of 28 days pills are there. So say they can take it easily, and we will say that after that you can start with the second one. And many things we are doing on regular basis. Then if we explain that we have to take the pill, it will be better. And all the pill use for 5 years is very much good for the female, because it has a regular cycle, less amount of blood loss, free from dysmenorrhea, and free from breast pain, and many times from fibroidosis, and it is also protected from ovarian cancer, ovarian cyst, breast, not breast cancer, but endometrial cancer, and many
Yes, I would
others.
like to say something.
With education, I think the OCP, low dose OCP will be the best for these groups, if they can take it.
Dr. Datta, Dr. Archana was saying that yes, we can make aware with tender loving care and all, but what I had presented was the WHO data, and it clearly shows that unacceptability has been going on for years and years. We have been giving, but it is left over. In a year or two, it is left over. Long term, it is not being taken just because of fear of either some menstrual disorder or because of the fear of carcinoma. Both the things are there. So because of the fear, they just leave it. And there comes the factor what we should do. So the acceptability of the implant, if it is done by government, which Dr. Shobha Gudi has been working and working, that if the government takes it up, it will be a good thing. That is what I agree. And OCP pill, we have an experience of 30 years. People are not accepting, people are not taking it regularly. They don't understand it. And making it understand is a very difficult thing, and that is reflected in the worldwide data which we have shown.
Thank you, Madam Speaker.
Thank you. Thank you.
Thank you, Madam Speaker. We have got constraint of time, but while sitting here, I just would like to bring up an issue. We
Thank you,
got
ma'am.
a little less than 25 million unwanted, unintended, and unplanned pregnancies in the country right now. And our important duty is to prevent these unwanted, unplanned, and unintended pregnancies. We wish that every pregnancy should be a wanted one with periconceptional administration of folic acid, which is biologically required. And secondly, use of condoms in the teenagers, it may play a very important role, because when I visited some of the African countries, they used to provide condom free of cost in easily available areas, so that there is no indignity in picking up the condom from places. With this, I wind up this discussion, and thank you very much, Madam, for your wonderful talk.
Thank you, ma'am, for your comprehensive presentation, and thank you, sir, for chairing this session. I would like to call Professor L. Ranjit Singh to come over stage and felicitate Dr. Rekha Jha, ma'am. Ma'am Rekha Jha, can you please come to the stage, sir, will be felicitated. Next, we'll go with the professional ethics in clinical practice. I would like to call the chairperson, Dr. Sudhir Adhikari, and Dr. C.H. Pritam Kumar Singh to kindly come over stage and chair the session.
Good afternoon, everybody. So everywhere there is changes. The session 7 has come earlier than 6 and 5. Now in this session we have T.H. Meera, Sub-Dean. The talk will be on professional ethics in clinical practice. Dr. Meera, Sub-Dean Exam, RIMS Imphal, former Member Secretary Research Ethics Board, RIMS, Chairperson Institutional Ethics Committee, Churachandpur Medical College. The new medical college came up in the state. Faculty of Medical Education Unit, RIMS, teaching forensic medicine as well as medical ethics for last 27 years. Is dedicated to upholding medical ethics and delivering quality education. Dr. T.H. Meera, please.
Thank you, sir. Very good afternoon. And first of all, I'd like to thank the organizers for having me here today and of course managing the time slot for me. I have some exigencies of work at home. I have been given the topic of professional ethics. So as a part of the professional ethics, I would like to talk about the unethical acts in clinical practice, the practices that compromise patient care and trust. There's other points to be discussed. Under this heading, we'll be discussing this. And I, of course, have a disclaimer before I start, because there may be certain misunderstandings towards this presentation of mine. So I have no intention to offend anyone. First of all, medical ethics. Medical ethics is nothing but the moral principles which guide this. This is the disclaimer that I want to put up. Then the 4 principles of ethics are there. Ethics is basically what is morally right or wrong in dealing with patients. The 4 principles are autonomy, that is respecting the patient's freedom to make own decisions. Beneficence is whatever the doctor is doing should be acting in the interest of the patient, providing benefits. Third is the principle of non-maleficence. Whatever the doctor is doing should not harm the patient. And the 4th is justice, that is treating all the patients with fairness and with impartiality. Now there are certain unethical acts, and this unethical act include, this is basically unethical act is an act which is lacking moral principles and not in accord with the standards of medical profession. And there are many scopes of unethical practices, but some salient scopes for unethical acts in medical practice include financial exploitation of the patients, unnecessary procedures on the patients, malpractice of the doctors. And this includes non-disclosure of the conflict of interest. That is, the primary interest of the doctor is the welfare and the best interest of the patients. And the secondary interest is his own interest, his personal gains. And when this secondary interest outweighs the personal interest, we call it the presence of the existence of conflict of interest in the forms of kickbacks, that is payment in exchange for a referral, prescribing unnecessary tests and procedures, fee splitting or cuts, that is splitting the fee between the doctor and the third party, commission, that is to prescribe certain medicines in return for pharma companies sponsored holidays, gifts, attending conferences in exotic places. And of course, other acts include overcharging the patient, exploiting the patient's vulnerability, inadequate informed consent from the patient, engaging in malpractice, that is negligence and improper treatment, and of course the discrimination of the patient based on socioeconomic background, and also disrespectful behavior towards the patients who belong to the lower social strata of the society. Now, there are some, I'm just showing some examples of unethical acts which grossly violate the principles of beneficence, non-maleficence, and the autonomy. That is, performing surgeries without a valid medical reason solely for financial gain or personal interest, subjecting the patients to unnecessary investigations leading to financial exploitation, prescribing costly medications that are not required or appropriate, often for financial incentives, failing to provide relevant information and unnecessary referral of the patient for kickbacks, neglecting patients by failing to provide appropriate time, follow-up, consultation, or referral, which may result in harm and compromised outcomes. Of course, there have been some dissenting voices from the fraternity, from the medical fraternity, in the forms of articles in the newspapers, articles in the journals, even like the BMJ, in the TV shows, and of course a book has even come out. Coincidentally, this was edited by a practicing gynecologist. And some of these dissenting voices include full body investigations advised are without any indications. For kickbacks, I found my junior colleagues advising investigations worth rupees 10,000 for the diagnosis of just a ganglion. This is said by a senior consultant in the hospital. A gynecologist in the Metro Hospital says for pregnant women who are in good health, they repeatedly prescribe hemogram, kidney function tests, and liver function tests just for kickbacks. Many gynecologists do not tediously spend 14 to 16 hours taking care of patient in labor. What is the return that one would get after devoting so much of time? It is far more convenient and profitable just to perform a quick cesarean section, says a city-based gynecologist. Another general practitioner in Nasik says for referring a case for angioplasty, a doctor gets rupees 30,000 to 40,000. Illicit arrangement is made whereby patients from the public hospitals are siphoned off to the private hospitals under some pretext or the other, says the general practitioner in a small town. Running a lab is very difficult without giving commission to the doctors, as no patients are sent to us, says a lab owner, a pathologist in the metro. It is usually 10%, but almost all the labs give 50% commission in my area, and sometimes the commissions are more than the fees of the doctor, and in some areas the commission rates for x-rays are 25% and 33% for MRIs and for CTs. A super specialist in a corporate hospital says every month in the meeting the CEO reprimands because instead of having 40% conversion rate for OPD to operative as a target, my conversion rate is just 10 to 15%. Treatments are no longer in the interest of the patients but the profit of the stakeholders of the hospital. The author of the book says CMEs are no longer conducted through subscriptions from the members but sponsored by the pharma companies in the present times, and they cover the cost for the conference in India and abroad to promote their medicines and devices. A pediatrician in a metro says sometimes the pharma companies select the topics to promote their drugs and devices. Consequently, to reciprocate the accepted money and gifts, we are morally obliged to repay by prescribing what has been dictated by these companies. These are some of the voices, dissenting voices. Now, having said all this, what is in vogue in the society? The criteria for a doctor's success set by a society in the present changing trend of patient care is a successful doctor is the one who has big cars, who has big mansions, and who earns a lot of money. This is a changing concept. Again, what is the bitter truth? Having said this, what is the bitter truth? The bitter truth is when a doctor takes favors and indulges in unethical practice, the strain is on the patient's pockets and his welfare. So what are the expected consequences of the unethical acts? That is deterioration of the doctor-patient relationship, loss of credibility of the doctor. The patients may start doubting the integrity and may lose faith in the doctors. The patient's autonomy and the patient's safety may be compromised. Then of course, legal and professional repercussions from the statute body also expected in the form of damage to the reputation or potential lawsuits. There are certain guidelines and regulations against the unethical practices. In India, we have the National Medical Commission guidelines. It talks about the objectives of the medical profession, which should be solely for the service of humanity, not thinking about reward or financial gain, and exposure to the any doctor, if he thinks that one of his fellow colleague is indulging in unethical practice, then he should be exposing such unethical conduct. And are certain guidelines given by the NMC also not to receive any gifts, any commission, and the punishment, that is a penalty in the forms of erasure of the name or fine. Again, the Charter of Human Rights led down a National Human Rights Commission. According to them, the patient's rights are the human rights. The patient should have the right to choose alternative treatment options if available, and should not be compelled to follow certain treatment without their will, and should have the right to choose the source of obtaining the medicines, that is from where they have to purchase it from, and of course the right to referral and transfer, which is free from any perverse, any commercial influence or interest of the doctor. So the attention of the human rights may be attracted if such unethical acts are performed by the doctor, indulgent in unethical acts. Then the pharmaceutical companies have their own uniform code of pharmaceutical marketing practices. According to this, no gifts, no travel facilities to foreign countries, vacations for the doctor or his family members, or sponsorships for attending the conference, no hospitality like hotel accommodations or payment in cash to the doctor or his family, is the uniform code of conduct. For this is actually not a law but just a guideline. And there is also the offense for the existence of conflict of interest is considered as the when the doctor is prescribing medicines in lieu of the commission from the pharmaceutical company, or referring to any other individual for financial interest, then this may attract the attention of the Prevention of Corruption Act, because this is an offense of bribery, as there's existence of conflict of interest. In foreign countries, we have the Physicians and Science Act, where the doctor is supposed to declare everything about the General Medical Council Act. The UK has got this guidelines for not to indulge in all these practices. Even the American Medical Association, they are also very strict about it, no reference for endorsement. Having said all about this unethical acts, the voices of dissent, everything, there are certain points to ponder. That is, why such indulgence in unethical practice by doctors? Is it because there's no fear, no dirt of there is dirt of whistleblowers, or is it that the doctors have become too materialistic, or is it the ignorance of the existing guidelines by the doctors, or is it the IDC attitude, I don't care attitude towards the guidelines? Or is it the unsuspecting patients, or is it the improper implementation of the regulations? Now, all said and done, the road ahead is, please remember, the olden days, awareness levels of the patients regarding their rights and safety have increased globally, and so does the litigiousness of the patients. So what is recommended is the awareness of the existing guidelines and regulations by the doctor. And a very good policy is honesty, disclosure of whatever conflict of interest you have. You can have it in person or in print or in the statements. To conclude, what I want to say is our vision becomes clearer only when we look into our hearts. What goes around comes around. The future generation of the present-day doctors may not turn out to be very successful doctors, very rich and powerful people in the future. And God forbid, someday they may have to endure the same type of unethical practices that our present-day patients are facing, until and unless this menace of unethical practice is curbed. So, introspection, what is right or what is wrong by putting into the patient's shoes, is very, very important. And my take-home message is, not every doctor indulges in unethical acts. Several selfless, altruistic doctors practice without compromising the primary interests of the patients. So a collective effort to promote ethical conduct, rebuild the trust, and uphold patient-centered care, not only defensive medicine, is indeed the need of the hour. Thank you so much.
Thank you, madam, for beautiful presentation. And we know we are in the service of humanity. We should have a good relation with the patients and patients' family members. And it is clear that we should not do anything unethical in our profession. So, if there is anything not clear to me, you can ask madam. Thank you, madam, for your beautiful presentation again.
Thank you, ma'am, and thank you, sir. Thank you, ma'am, for the elaborate and comprehensive presentation. Now, I would like to call upon Chairperson of this session, Dr. Sudhir Adhikari, sir, to present Dr. T.H. Meera, the speaker of this session. Let's give a round of applause. Thank you, ma'am, and thank you, sir. Next, moving on to session 4, I would like to call on stage chairpersons for the session, Dr. L. Ranjit Singh, President of Manipur Medical Council and former HOD of RIMS Imphal, and Dr. Ashma Rana, the Unit Chief and HOD at Tribhuvan University Teaching Hospital, Kathmandu, Nepal, to chair the session, a keynote address by the Secretary General FOGSI. Over to you, sirs.
Good afternoon, everybody. It gives me an immense pleasure to introduce Dr. Madhuri Patel, whom I have been knowing for ages. She's been a very, very sweet person and a sweet friend of mine, and she has a very excellent CV. She's an MD/DG, FICOG, Honorable Clinical Associate, Nourasia Wadia Maternity Hospital, Mumbai. She's well known to you as a secretary and the first female secretary general of FOGSI, which is a great pleasure for all womanhood, and former committee member of FIGO, Preterm Birth, associate editor of Journal of Obstetrics and Gynecology of India. That's a big pride. Honorable Consultant, Police Hospital, Mumbai, visiting consultant in St. Elizabeth Hospital, Mumbai, former professor in HOD, OBGY, ISIC, PGIMER, Mumbai, former associate professor of GMC, Mumbai, India. The floor is yours, Madhuri. It's so pleasant to hear from you.
Asma, thank you very much. She is my dear friend, since many years. I think you were Suffolk president that time I met you. And since then we are friends and forever. And Ranjit sir, I am really impressed. You were the past HOD. And I am really impressed. Yesterday we had a fix-up workshop. The way he put so many questions to me, I hope I have answered you, satisfactorily. So, respected chairperson, my seniors, I can see Dr. Basav, Rekha, J.B. Sharma, Archana, all Pratima, I can see Archana, I'm calling by the first name because you all are my good friend, Alka, and all of you. Very good afternoon to all of you. At the outset, I would like to thank Dr. Rishikesh Pai, Dr. Alka Pandey, and Pratima, Dr. Subodh, and all entire, Imphal society for giving me this opportunity. Today I have selected a topic on conservative surgical management in atonic PPH. We are aware that PPH is a major cause of maternal mortality and morbidity, and atonic PPH is 70% attributes to atonic PPH, and majority of the atonic PPH are preventable. So I will only restrict to the conservative surgical management of PPH. So as all of us are aware that PPH is a serious life-threatening condition, and it has remained one of the major leading cause of maternal mortality and morbidity, not only in developing countries but also in the developed world. So if you see the incidence, each year 14 million women suffer from postpartum hemorrhage, and every year 70,000 maternal deaths occur due to PPH globally, and thus PPH contributes 27% of the maternal mortality. If you see the scenario in India, 2 to 4% it occurs following vaginal delivery, 6% following cesarean section, and overall it is 8 to 10%, and higher with the high risk factor. So in India it contributes 19.9% maternal death due to PPH. And as you know, the anemia is very common in our country. Even the government has done so many, control program, prophylaxis, but still anemia has remained high prevalence, and that is also one of the direct or the indirect cause of PPH. So all of you told which contributes 70%, atonic, which is majority of time is preventable, trauma, tissue, and thrombin. So what are the consequences? It can cause into hypovolemic shock, DIC, renal failure, hepatic failure, ARDS, and ultimately maternal death. Traditionally, all atonic PPH are treated either by medically, mechanically, and definite surgical line. But since last 2 to 3 decades, conservative surgical procedures have been successfully used in various circumstances and forms. Before going to the surgical conservative management, I would like to mention about of course there are preventive measures which I am not going into, but at least in the treatment part, your first response PPH bundle. That is E-motive. E-motive means early diagnosis, M means massaging of the uterus, O is oxytocin, T is tranexamic acid, IV fluids, and escalation, or sometimes you may mistakenly diagnose atonic for the traumatic or miss you have to do at this stage. At the same time, IV fluids are very, very important. If oxytocin is not available, you can go for other uterotonic drugs. And now if they don't respond with the first bundle drug, then it is a refractory. We can have compressive measures, especially when we want to transfer the patient to the higher center. Then we can have aortic compression, bimanual uterine massage, intrauterine balloon catheter, non-pneumatic anti-shock garment, and SR cannula, which is really they are using in South, which creates the vacuum and stops the atonic PPH. In the meantime, you can continue IV fluid, tranexamic acid, and oxytocin trip. So what is the mode of action of conservative surgical management? It controls PPH, it preserves the reproductive function, and avoids hysterectomy-related complications and consequences. So the main approach now depends on the clinical situation, the skill of the operator, and the technology available. So these are the conservative line of treatment, which is manual removal of placenta if the placenta is not separated, but nowadays we have to be worried about past. So majority of us have sonography, which is diagnosed before in advance, unless the patient comes to you at the last moment. Exploration of the uterus when the part of placenta or membrane remains. Exploration is a must, removal is a must, otherwise PPH is not going to stop. B-leaf suture, uterine and oval artery ligation, what is called as stepwise devascularization of the uterus, internal iliac artery ligation. COMOG, that is compression suture, along with the occlusion of the uterine arteries, uterine artery ligation with cervico-ischemic suture, and of course uterine artery embolization. Battery is low, huh? Battery is low. Can you put the? So this is a Beelish, which we say compressive suture, and it was introduced by Beelish in 1997, and now we all are well versed with this Beelish operation. It is a simple, effective, relatively safe, and requires minimum expertise. A woman meets the criteria for the Beelish compression when you compress the uterus, the bleeding reduces on cesarean section or abdomen, otherwise if vaginal delivery it is. And there are many modified operations which in the beginning came as Chaw, Heyman, Pereira, etc. So now this is the one which I am doing is a modified one where we have already done a cesarean, we have put a suture also in the uterine incision, but we want to do the compress the uterus. So you can modify yourself which you are comfortable. So we are taking out from posterior to anterior part suture. Another suture will be taking similar manner and you can tie together. So basic idea is that you are compressing the uterus. So whatever way you are comfortable, you can do it. Beelish has done with the open start and he has done, but you can do with the open and close incision, you can do it. So the success rate of compression suture is achieving hemostasis about 76 to 100%. In the 3 original studies for Beelish, Heyman and Pereira, they gave 100% result. And in a systemic review, the overall success rate of compression suture was reported to be 91.7%. So what are the complications? That they have not reported any death. Complications include uterine synecdoche, ischemia, uterine necrosis, intrauterine infection, and strangulation of the intestinal loop and abdominal omentum if you have used non-absorbable. I want to stress upon when you use non-absorbable, uterus contracts, so the suture will remain the same size and the loop can go inside. It's not working. Still many errors. Anyhow, I will continue. Alright. I just wanted to show more videos, that's why I'm just waiting for 1 minute. So the figure recommends compression suture as one of the options to control atonic PPH when medical and non-surgical treatment modalities fail. So let us come to the stepwise devascularization of the uterus. It was first reported in Egypt in 1960. It is effective in controlling PPH by 80%. So what we do, unilateral uterine artery ligation, bilateral uterine artery ligation. Some people like to take upper part of the uterine incision, and some people like to take even the lower part of the, after mobilizing the bladder, lower part of the uterine artery. that is, and then unilateral ovarian vessel ligation and bilateral ovarian vessel ligation. All of us are aware that 90% of the blood supply of the uterus occurs in pregnancy from uterine vessels. Ligation of the uterine arteries result in the significant reduction in blood flow to the uterus. It is a simple, fast performing technique. FIGO recommends uterine artery ligation as one of the options to rapidly control atonic PPH when medical, non-surgical approaches and the compression sutures fail. I want to tell you, when you ligate the uterine artery, then the blanching of the uterus occurs and the bleeding reduces. But if you don't see that bleeding continues, this is the uterine artery ligation. You can go 2 cm below the uterine scar incision and 2 cm deep, or you can come out from the peritoneum, go back and take the uterine artery ligation. Remember, if you go lower than that, you may injure the ureter. So when you come for the ovarian artery ligation, if the blanching doesn't occur after the uterine artery ligation, the bleeding continues, then you have to go and take the ovarian artery ligation. Ovarian artery directly arises from the aorta. Anastomosis with the uterine tree in the region of the uterine aspect of the ovarian ligament takes place, and this is a video where you can see we are ligating. You can see the fallopian tube, you can see the meso-ovarium, and you have to take a stitch just below that towards the utero-ovarian ligament. In case it is difficult to identify, then you can take a ligation, you can do the ligation of the infundibulopelvic ligament. So now let us come to the internal iliac artery ligation. Experiment in 1960 by Brussels ascertained that the effect of ligation of the internal iliac artery to convert the arterial flow into the venous flow. So the flow decreases, clot formation occurs, and it remains there, and thus it reduces the postpartum hemorrhage. So it is effective uterine atony, midline perforation, large broad ligament or lateral pelvic wall hematoma, multiple cervical tears, lower segment bleeding, less effective in PAs, placenta acquisa syndrome, and not useful for uterine laceration. So it should be done by the surgeon who is used to operate in the retroperitoneal space, and the surgeon has to decide, clinician has to decide whether you should go for the internal iliac ligation or you should go for the definite line of surgery. Because what will happen, if you waste time, patient is not stable, you do internal iliac ligation, it is not coming under control, you are wasting time, it is better to do definite surgery, that is obstetric hysterectomy. So ultimately the clinician will decide whether they should go for internal iliac or obstetric hysterectomy. So surgical anatomy, you are aware at L4, that is pelvic beam, the common iliac artery divides into external iliac artery and internal iliac artery, and after 3 cm, the internal iliac artery divides into the anterior and posterior division. These are the branches of anterior division and posterior division. I am not going into detail, but I would like to say we can use two methods, direct method or indirect method for the internal iliac ligation. So you can see here in the video, if it is following vaginal delivery or during cesarean section, you can see we have to open the peritoneum. Of course, you have to deliver the uterus, retract on the other side, open the peritoneum between fallopian tube and the round ligament and go laterally, and you will find psoas muscle. On psoas muscle, you can see external iliac artery, and you have to trace it caudally. So now we are tracing this external iliac artery upward. At the same time, when you are tracing, you have to take care of the ureter, which you have to retract medially. So now we are tracing and we will reach upward, we will reach to the common iliac vessel. You can see the common iliac vessel, and now you are identifying the internal iliac artery. Now there are two methods. You can go directly below the internal iliac artery, but you have to be worried about the internal iliac vein, which is posterolateral, and there are more chances of injuring this. And if you injure internal iliac vein, it will torrential bleed and patient can die on the table. So this is a direct method when mixture is inserted, and to show the other side indirect, we are just pulling the gauze piece and pulling it. Now, this is a common iliac artery. When we are going below the common iliac artery, and now we are taking out the suture from common iliac artery. Now this is indirect method. So now we are going below the external iliac artery and we are pulling the suture from there, and you will find the magic that when you pull the thread, what happens? Just see that when you pull the thread, you are at the internal iliac artery, right? So this is the reason why the indirect method is good, because you avoid the injury to the internal iliac vein. And after this, remember one thing, you have to cut the sheath of the artery. If you don't cut the sheath of the artery, the suture will not be tied and it will not serve the purpose. So 3 centimeter below the internal iliac artery, you take suture, and the bleeding will stop. So there are certain facts you have to remember about internal iliac artery ligation. Femoral pulse should be palpated before and after ligation. Absorbable sutures were used to help recanalization after primary objective serve, but it doesn't make any difference. But it is used for, as I said, bilateral atonic PPH, you should do, but unilateral can be done for the broad ligament hematoma. After ligation of the internal iliac artery, the collateral circulation occurs within 45 to 60 seconds. Meantime, the PP is under control. So this is about internal iliac ligation, and there are various studies have reported that internal iliac ligation was effective in 75 to 81% to 95% of cases with this internal iliac ligation, and there was subsequently no fertility problem or the pregnancy outcome. Now there is something called as compression suture with occlusion of the uterine artery. So what happens? It gives a double advantage. You take a uterine artery ligation, at the same time you do billing, compression suture. So it reduces the flow tremendously and PPH under control. So we have from our Dr. Mahesh Gupta, who has done from Ahmedabad, who has done a PPH conclave just 6 months back, and he presented his paper which was published in our Jubilee in 2020 that he did for 3 patients, and he reported the postpartum menstrual flow and the breastfeeding were normal, which ultrasound confirmed that the endometrium and the ureter were normal, and the hysteroscopy showed a normal uterine cavity in all 3 women, and one subsequent full-term pregnancy occurred after 6 years of their surgery of a 27-year-old woman who delivered with C-section. So let us look at the uterine artery ligation with cervico-ischemic suture. This is very, very important. When there is a placenta accreta syndrome, majority of the time we go for the cesarean hysterectomy. But now this is another conservative surgery. The results are good. That is, you ligate the uterine artery and you take a 2 stitch, as the picture shows, at the level of cervico-ischemic area, anterior to posterior and posterior to anterior. Take 2 stitch. When you are tying this stitch, my lecture is for 30 minutes. Huh? When you are tying the stitch, you put a dilator in the cervical canal and then you tie, and so your cervical canal is not obliterated. Many of the time, what the obstetrician do, they deliver the baby, take the uterine artery ligation, take the cervico-ischemic stitch, and then remove the placenta. So that is, you find really very less bleeding, and this conservative approach can reduce the obstetric hysterectomy for the placenta accreta syndrome. Of course, now the selective artery embolization I have taken is a conservative surgical management, so it is up to you to decide whether it is a conservative surgical management or it is a part of the treatment, other treatment, but it is available in the specialized center and the expert is required, and this is you can do prophylactically when you find that PPA you are dealing with placenta accreta syndrome, alternative to obstetric hysterectomy, persistent bleeding after hysterectomy, and bleeding due to cervical or vaginal laceration. So what we do, we catheterize to the femoral artery up to the internal iliac artery to the uterine artery, and when If you require, if it says that now the PPH has to be under control, we push gelatin, particles, it causes temporary block, it gets dissolved and the reconsolidation occurs. But nowadays we use endovascular bag and which temporarily it will, block it, the uterine artery, and temperature is under control, and then you can release this. The success rate have been reported 90% with low complication rate. Ojala et al. Described series of cases in patients who underwent embolization reported 80% as a success rate. So there are certain complications which are 8.7% and most common is low grade fever. Less common are pelvic infections, growing hematoma, iliac artery perforation, transient buttock ischemia, transient foot ischemia and bladder gangrene. Lee et al. Reported dissection of the uterine arteries, hematoma at the puncture site, paresthesia and lower limb edema as complications. Some studies have documented resumption of menses and even pregnancies after this procedure. So to conclude, atonic PPH is a major cause of the maternal morbidity and mortality. Conservative surgical procedure is effective, preserves fertility and prevents hysterectomy related complications and consequences. If situation demands, one should not hesitate to perform obstetric hysterectomy. Obstetricians should expertise with all these surgical methods. Timely surgical intervention reduces maternal mortality and morbidity tremendously. So as I mentioned, we have FOGSI, we have FOGSI Manyata flagship program where 45% of the delivery occurs in private sector. We enroll our private sector, nursing home where we teach not only the obstetrician but paramedics also about the standard 16 points of antenatal, intrapartum and postnatal care. Then we have FOGSI PPH project which happened in UP because it is a high mortality rate, they have maternal mortality. So donors like to concentrate on the high mortality, maternal mortality rate, states. And we have FOGSI PIGO, I have mentioned in the inauguration, that is Leadership Development Initiative, and we have selected the two projects, that is emotive and iron, parenteral iron in anemia patients. And of course, Dr. Rishikesh has done Nana Anemia Yatra. Then WHO Summit, Dr. Rishikesh presented WHO Summit on PPA, and FOGSI is always a part of policies when the government make the policies. FOGSI is also every time part of it. So reset, refocus, readjust, restart as many times as you need to, just never give up. Let's ensure no mother dies of PPA. I thank all of you for the patient hearing.
Thank you, Madam, for the wonderful talk. It's very infrequent to do selective artery embolization in many parts of the country, but I'm sure some of the centers in the country, they are doing. Right now, for example, All India Institute of Medical Sciences, New Delhi, but we need the presence of the interventional radiologists. In emergency, it's very difficult to find their service. Any idea, Sir J.V. Sharma, would you highlight? Because I know it is done in IMS, embolization. Yes. Okay.
I mean, we just have a look whether a placenta is separating or not. If not, then we don't try to do anything. We just go ahead with hysterectomy, and when after taking the baby out, then we inflate the balloons. Okay, that with us, and then usually with this the blood this is controlled, and PPH can be reduced to almost 1.5 to 2 liters is our average loss for increta, accreta, percreta patients. Even percreta we have done that. So we are routinely doing that, and it has controlled. We are able to do almost 100% hysterectomy for those patients. Until now, I have done about 28 cases of such cases with some few my team, and we have saved almost all the patients.
Thank you. I would like to hear
But
something.
routinely for PPH patients, of course, we are not doing. I mean, we have the facility in the night where one radiology SR is available for that. But for PPH, because the patient is bleeding so much, so sending that patient to radiology becomes a tough decision, no? And they can't come there; it has to be done in their this thing. So even for PPH, we are not yet doing embolization.
So PPH is, Dr. Sharma, you are absolutely right. When PPH occurs, you cannot rush to the department. You will waste time. So it is when there is a high risk pregnancy, that time you do prophylactic and you should when it is required. But if PPH occurs, there is no point going there. On the contrary, if your this arterial embolization phase, then you take for the surgical line of treatment.
So you have to be prepared. You have to be good in surgical line management. Highlighted this because many PPH occur in unexpectedly.
Thank you, ladies.
Thank you.
Sir, we would like to hear from some of the Yuva FOGSIans, since it is for them. It's very important part of the discussion. Before I wind up, I would like to say one thing. We had launched a program called as National Nutritional Anemia Prophylaxis Program in the year 1970, which was changed to 2018. It was changed to Anemia Mukt Bharat by the current BJP ministry, and with that we had a great improvement in the status of the hemoglobin or blood among the pregnant women, because anemia, even if not the direct cause, is one of the very important leading cause of indirect cause of maternal death. So we have to keep hemoglobin of the pregnant women as high as possible during pregnancy so that we can save their lives. Thank you very much.
Thank you.
Thank you, ma'am, for your informative presentation. I would like to call the chairperson of this session, Professor L. Ranjit Singh and Dr. Asma Rana, ma'am, to kindly felicitate Dr. Madhuri Patel, ma'am. Thank you, ma'am and sir, for chairing this session. We'll go with the session number 3. As we are running out of time or as we are going late, so we'll request the speakers to kindly stick onto the time and if possible to kindly shorten your presentation. I would like to call the chairperson for session 3 on recent updates, Dr. N. Subodha Singh, President IOGS Imphal, and Dr. C.H. Mangling Singh, former Professor in RIMS and Managing Director, Imphal Hospital, to kindly come over stage and chair the session. Dr. N. Subodha Singh, sir, and Dr. Mangling Singh, sir.
Good afternoon, everybody. This session has been long due, and we thank both madams for being so patient with us. And first talk will be delivered by Dr. Anuradha Panda. She is MD, DGO, FI, COG, a senior consultant in Ops and Gynae, laparoscopic and robotic surgeon, Apollo Health City, Jubilee Hills, Hyderabad. She was a brilliant student, has got so many awards during MBBS, including the best outgoing student, and she has been awarded for Inspiring Gynecologist of South India in 2019, Legend of the Year 2019-20, given by Times Healthcare, a silver award. She was awarded mentor for MIS and robotic surgery fellowship, Apollo Hospitals, organized live surgical workshops in TLS and cadaver workshops in urogynecology. She has many fellowships and trainings, and just to mention a few, fellow when State University, Detroit, training in advanced MIS in Ethicon Institute, training in robotic surgery, FOGSI, publications of articles in many journals, co-editor in FOGSI, Focus MTP, in high-risk pregnancy, member of FOGSI MTP committee, and she has organized live surgical and hands-on workshops in laparoscopy, hysteroscopy, TLS, and cadaver workshop in urogynecology. Robotic surgery is something very new to most of us. We don't have much idea, so we'll learn from Vedabhu. The floor is yours, ma'am. Thank you.
Thank you, sir, for your kind introduction, and thank you organizers, mainly Dr. Praneshwari, who had given me the opportunity, and Dr. Pratima. I'll go ahead with my topic, robotic surgery in complex hysterectomy. As you all know, robot is a new addition in minimally invasive surgery, but when you do it in uncomplicated cases, simple surgeries, you find the time taken will be more, and even you will have the cost of hysterectomy going up. So most of us would debate, in a country like India, would it stand a chance? Like when you do complex cases, sometimes you find laparoscopy as a challenge. This laparoscopic instruments are straight stick instruments, and sometimes it may be difficult to reach very deep into the pelvis, and need to convert to laparotomy may also be higher. But then let us see, can robotic surgery bridge this gap for us? The criteria for complex cases, well, even that is strongly influenced by the surgeon's skill and may differ from person to person. Some would say 250 grams would be big, some would say a 501 would be big. But we'll all agree that in multiple laparotomies is always a challenge. Adhesions, and in endometriosis, advanced stage 3 and stage 4 endometriosis, multiple large fibroids, mainly in difficult places like low down in the pelvis. They make this uterus very broad, and it may be difficult for us to do the surgery. Obese patients, all of us would see how we struggle and our assistants struggle, and the instruments may not reach. We need bariatric instruments, and then we have a lot of struggle. So when you use a robo, like what we use is a Da Vinci XI system, the most advanced one, the 3 8 mm ports, and you can have one more port here because the robot has 4 arms, but each additional port and additional instrument would cost for the patient. And then you can add this 5 mm ports. What I do is, when it's more complex, take one more 5 mm here, and then you can handle it with 3 arms. Then after that the robo is docked, and then the surgery is started. Well, let us come to the first case, which is adhesiolysis in a captive uterus syndrome, a 45-year-old lady with one previous cesarean with a BMI of 30. She had medical treatment, didn't respond. She had a VP scan for hydrocephalus 5 years back, and the uterus was big, 16 weeks irregular. Ultrasound showed large number of fibroids. And in these cases, when you go in, I found that the uterus is stuck. Only the fundus, a portion of it is seen. The bladder is all adherent. The bowels are all stuck there. And then when you start the adhesiolysis with the robotic instruments, you find it works like endo-wrist instruments. They work like the wrist of your hand. It's like replicating the open surgery there. And you see, with a 3D vision, the planes are very clear. So the dissection becomes easier. This is a monopolar scissor, which you can use like a scissor, or you can even without current, you can use like a scissor or use as a monopolar cautery. It works well. Your two instruments will be okay. On the left hand, bipolar forceps, and on the right hand is the monopolar scissors. And slowly you find the anatomy is coming to light. Here you see the planes are very well seen. And first you make the anatomy proper, go to normal anatomy, and then only you can proceed and do a hysterectomy in these cases. And nowadays, when you put a little vasopressin into the uterus, previously I was not, the bleeding was little more, but when you inject vasopressin in difficult cases, you find things better. and slowly the ventrofixed uterus has to be released, and then it would be the bladder, and we have to fill in the bladder with Michelin blue and see delineate the limits of the bladder before going ahead. A similar case, most of the time now we find with so many cesareans, a ventrofixed uterus, and that too with lot of fibroids there. And slowly we have to dissect the fibroid out because they're going even into the bladder. And mind you, in these cases, whatever manipulator you put, we cannot reach, we cannot even manipulate the uterus well without using a myoma screw. Slowly, one by one, the fibroids have come out. Always check the bladder again and again, 2-3 times maybe in between the surgeries to delineate the plane. The posterior planes are much better here because anteriorly, because of cesarean, there is so much of adhesion. Posteriorly, you can go ahead and on the blue tube or whatever manipulator you have, do the colpotomy. You find how the bladder is looking with the anterior wall is looking with so much of dissection and adhesiolysis. So always do a cystoscopy at the end so that you are very sure about the integrity of the ureter and even the bladder. I am using a V-lock suture, taking both the uterosacrals to prevent a wall collapse. This is a case of a 48-year-old lady with post-bariatric surgery. She had a BMI of 38 with anemia and morbid obesity and previous 2 cesareans. And in the beginning, the whole abdomen was so plastered. These all adhesiolysis had to be done first before the robo could be docked. I'll go a little faster. And then there's many fibroids, and the fibroid is occupying in the anterior segment around 8 cm fibroid, and in these cases the chance of bladder injury would be more. The fibroid may have to be dissected out. The planes would be a little difficult to reach because of those caesareans and the bladder adherent in planes, and slowly even after dissecting I found that I had made a hole in the bladder. So again I had to go back, dissect separate few more fibroids and go again in the plane. When I change the manipulator, put a blue tube in so that you can see the lip, at least you get the surface on which to dissect the bladder. The bladder, even the suturing can be done easily in 2 layers, and see that it's watertight by injecting after the procedure, and then carry ahead with the cystectomy. What does literature say? The perioperative outcome of robotic assisted hysterectomy for benign cases in complex pathology. This is a much cited article by John Borges, and they said that it takes less time, less blood loss, and you can use it for complex cases. It would be a feasible option with shorter hospital stay and low morbidity. But they again said that the uterine weight was more than 250 grams. It took long time because the morcellation did take longer. What about obese patients? This systematic review over many years, they had found that these patients were all patients who had endometrial CA, hypertensive diabetes and obese. They at the end of the study they found that especially in obese patients, this can optimize the surgical outcome equally well if not better, but always we find that in very obese patients with very high BMIs, we are really at a comfortable position when we operate laparoscopically, robotically. This is a large uterus around adenomyosis, very big one with severe endometriosis. And in this patient, she was only 42, but she had so much pain, she was not responding to anything. So I had to do a robotic hysterectomy with bilateral salpingate oophorectomy and then put her an HRT later. In these conditions, when such big uteruses, you have to have a good manipulator, and most of the time you would find the instruments will really help you. And in this case, she also had a nodule as well on the uterosacral ligament. When you come behind, there was so much endometriosis, the bowel was all stuck, I started and it was very difficult actually. I had to call my colorectal colleague to help me with that. Because in these cases we have to be careful. There is no anatomy. Here you see the PO mass. Everything is stuck. And you slowly release the bowel also from the POD. The uterus had extended to the lateral wall, and you see the ureter lysis done. We have to be very careful when we are doing that. Only after that care should be taking the doing a colpotomy or taking the uterine. Otherwise there is high chance that we take the ureter or cut it off. In most of these cases, when we handle the bowel so much, at the end of the procedure, we should have a air leak test done so that we are sure that we have not injured the bowel in any way. But at the same time, when there is thermal injury due to these instruments, they will always present late. So the section is done. I am going ahead with the colpotomy. And there also it is very hard. When you do a robotic, there is no touch sensation. I am feeling it is, I am not able to cut so much. I thick, and everywhere you have the endometriotic deposits. There is uterosacral nodule here. I'll forward it a little. Anteriorly, where the planes were all good. In most of the time, we find a good manipulator again helping. And here I have made the assistant feel, because for me it was taking a long time to cut. So she also felt it was a nodule which was not even detected on MRI. At the end of the case, this was a very big uterus. This is the nodule which is getting excised, and it really took a long time to oscillate the uterus and get it out vaginally. The air leak test being done. The air gas being inserted to the rectum, and the uterus was too big. It took around an hour to get it out, so I didn't dock, and I am closing it laparoscopically again. At the end, a cystoscopy was done to see the ureteric jet. I think that we as gynecologists in all complex surgeries, we should be doing that at the end of the procedure. My series of complex cases, around 60 in 5 years. The BMI was around 31 plus minus 7. The operative time, the specimen weight was around 475. The blood loss was less. Few injuries, one bladder injury which we have seen, and minimal conversion to minilap. This is the outcome influence of patient complexity, and here they found a very nice thing. When in high volume cases, the surgeon does, here they compared robotic to laparoscopic surgery, and they found when a high volume surgeon does robotic surgery in complex cases, actually he saves time. It's 21 minutes faster. Apart from less blood loss and other complications. To conclude, and there is a good article where the benign hysterectomy, where are we at the end of 10 years, and they found that more laparotomies came down once robot was introduced, and more of laparoscopy. Patients went more of for robotic surgery. That was a study from France, the FOGSI hospital, and they found more of less of conversion and more of patients going from laparoscopy to robotic, and male from open surgery to robotic procedure. To conclude, I will say the adoption of robotic surgery made minimal invasive surgery a valuable option in complex cases. Adhesive is far superior because of the endo-wrist instrumentation. Now, bladder injuries, bowel injuries can be tackled in the same sitting in a better way. The post-op pain score is less. There is less fatigue to the operating surgeon and even to the assistant. The conversion to laparotomy is low in complex cases. The most important thing I would say is a judicious selection of key. Just because you have the robo, you are not going to do for all cases. A judicious case selection where it helps the patient, is beneficial to patient, is the key while using this technique. Thank you very much.
Thank you, Dr. Anuradha. Very good surgery. Looks so easy when you do it. With advancement of technology, this robotic surgery and artificial intelligence, as Sir Rishikesh Pai has presented today, all of these will become an integral part of our practice very soon. So for the next talk, Sir Mangnem will do the proceedings.
As we are short of time, now I request that Dr. Ningalakang Bam from Kathmandu, that it looks like from Manipur. So she is presenting hysteroscopy in new respect.
So very good evening. Firstly, I would like to thank Imphal Obstetric and Gynae Society for inviting me, especially Dr. James and Dr. Fatima. So my topic for today is new aspects of hysteroscopy. I had put this two pictures before my topic. The reason behind is born in the land of Govindaji. Today I am settled in the holy place of Pashupatinath. So I am really blessed to come back to my home and present this topic. So there are lots and lots of myths about hysteroscopy. When we say hysteroscopy, even when I started hysteroscopy around 8 to 9 years back, many of my friends even commented me that what's here in hysteroscopy, what are you doing? You just need to put the hysteroscope inside the uterine cavity and just see the cavity only, which is not so, my dear friends. I would like to state that yesterday, even in the our endoscopic workshop, I had shown about the no-touch technique, that is without using any speculum or without holding the anterior lip of the cervix. You need to put your scope, have a good visual aspect of the vaginal cavity, that is the vaginoscopy, then the endocervical cavity, and finally the uterine cavity. So talking about the modern hysteroscopy, so we have moved on from our out of our operation theater, and we are doing our office hysteroscopy, that is the mini hysteroscopy. The mini hysteroscopy, the first picture is the mini hysteroscope, which looks almost similar like the hysteroscope which we are using in our operation theater. The difference only is that it has become smaller in size. Otherwise, it's almost similar. The inlet, the outlet, the light source, and the camera fitting, it's almost similar. But the second picture, I would like to focus on the second picture, that is the advanced endoscopy. This advanced endoscopy, I think according to source of Cooper Surgical, it was introduced in India in 2021, although it has been withdrawn from the market due to some registration process. So I would like to describe about this office hysteroscope also. The monitor, the LED monitor, it's a very handheld device. It's a very portable one, even we can take for our camps also. It is a single-use cannula. The cannula which is fitted in the handle, it's a single-use cannula. And the cannula, the tip, we can see that it's slightly angulated, and the tip is fitted with a 4.3 mm camera. And the best part of it is that the light source is inbuilt in it. So we don't need another machine to use for the light source. So the mini hysteroscope, as I have said, that is 1.9. Why I have written here 3 mm is with the outer sheet. Many of us gets confused that when we buy a scope and then we said, oh, what scope you're using, 1.9, then is it 3 mm? Then they said, no, it's not 3 mm, it is 1.9, which is not so. With the outer scope it becomes, with the outer sheet it becomes 3 mm. So why we have moved out of our operation theatre, the reason behind is in the office hysteroscopy, we don't need to prepare for the cervical dilatation. I think many of us are using misoprostol around 3 to 4 hours before the procedure. So in mini hysteroscope, we don't need to use any cervical preparation, no need of cervical dilatation or any anesthesia needed. The advantage, or the only advantage I see in EndoC is it's a handheld device and we can take it even in camps, not only in office as an office OPD procedure, and we can take still photos and videos. The HystroView, I think it was already in market long time back where the urologists were using it. They have the, it's written EuroView Incorporation. It was used by urologists a long time back, but in the market, in our gynae field, the HystroV, it also came around 2021. It's a 12 French semi-rigid. It is also a single-use portable one and the 0 degree. What's the difference between HystroV and EndoC is, in EndoC, the cannula, it's written as a single-use. I think many of us, even who are doing laparoscopic surgery, although the instruments which comes as a single-use, we are reusing it by re-sterilization. But the other disadvantage of EndoC, the cannula, is not only the single use, but which gets after putting it in the main handle, it works only for 1 hour. So in that time limitation, the I think when it was introduced in Indian market, it cost around 2,000. So the procedure was very high, cost affordability of the patients, like it was a little bit difficult to handle. So what I do in my practice is I collect 2 to 3 patients all together, and I use EndoC one patient. If I complete around in 5 to 10 minutes one procedure, put it in Cydex again, and I sterilize it, at least to reuse it in 2 to 3 cases. So few years back, we all were talking about intrauterine Begati's Hiv. I know many of us still today we are doing our polypectomy or myomectomy, hysteroscopic myomectomy, still with bipolar. I think many of us have shifted from unipolar to bipolar, because unipolar, due to high complication rate, we are not doing it anymore. Myself, even I'm using a bipolar resectoscope. But in the market, there are other varieties of instruments where we can perform hysteroscopic myomectomy or polypectomy. The one which is intrauterine Begati's shaver, it is just a double window blade. The advantage of this intrauterine Begati shaver is, while we are using a bipolar resectoscope, if the fibroid is very large and we are removing lots of tissue chips, it remains inside the uterine cavity, and sometimes it disturbs our visuality. Not only that, and sometimes due to bubbling, we are using the electrical thermal energy. That's the reason sometimes lots of bubblings are there and we are not able to perform the procedure very nicely. Whereas in intrauterine Begati shaver, it is not so, because it is just a mechanical procedure. It will remove the tissue chips at the time of the resection. That's the reason, and it has a good visual control and with less complications. So what is the game changer about the hysteroscopic myomectomy is the TrueClear Elite hysteroscope, which was introduced in Indian market in Mumbai last year. I was also there present in Mumbai. So it was introduced by Medtronic. Although this instrument was already in the market by Smith and John in 2005, but in Indian market it has just come last year. Smith and Jones has been overtaken by Medtronic. That's the reason it was introduced by Medtronic last year in Mumbai. It's also similarly like the intrauterine Begati shaver. Like it is completely a mechanical approach, and there is no scarring from thermal energy. While many of us who are already doing hysteroscopy, I usually do around 2 to 3 procedures of hysteroscopy every day. So many of us, why we want to change from our basic bipolar resectoscope to this TrueClear is the reason behind that. We will save our time, our operative time will be lesser, and visuality and complication rate. Although in bipolar resectoscope, the complications are also very less. I think it's very less from the unipolar ones, because once the time when people, the surgeons were using unipolar resectoscopy, I think there were lots of complications because of the energy source. But whereas in bipolar, it is not so. So it is really a good instrument, TrueClear. I have used it personally, and it's really a good one. So the Myosure, it was introduced by hologram, and it has got a complete package. The pictures which I have put down is the 4 instruments. The last one is the manual one. It is just for doing a simple biopsy or performing a polypectomy, which is almost less than 1 centimeter. The second one is around 1 to 3 centimeter. The third instrument is around 3 centimeter. And the last one, the Excel one, where we can perform even myomectomies of 3 to 5 centimeter. So it is like, people might think that we cannot perform hysteroscopic myomectomy if it is the size is more than 3 to 5 centimeter or around 5 centimeter, which is not so. I usually, if I'm using a bipolar resectoscope, I scoop out how much ever I can scoop out in the first sitting, and I repeat, and I counsel the patient and patient party that we need to do a second sitting, and usually I complete in second sitting. But I usually make sure that I see the uterine cavity again in next cycle without any anesthesia, that is the office hysteroscope. So the diode laser, I think many of us are very eager to know about this diode laser, but it's very expensive. It has 2 wavelengths. The simple funda behind the diode laser is it cut, it vaporizes, and it at the same time it gives a good hemostasis. So yes, we have heard of robotic laparoscopic surgery. So I think many of us would also like to know about robotic operated hysteroscopy. So if we go into the Journal of Minimal Invasive Gynecology, we can see a study which was conducted in 2020, which in that study they have used 2 surgical handed technique where they have put a uterine polyp in the porcine uterine mass. So it is still in research. So the time has changed, my dear friends. We are still in our blind procedure. This is a study which was conducted, which was published only 22 days back, where they have done primary resectoscopic treatment of first trimester miscarriage. Although it was a very small study, only 15 patients were taken. The study was done in Canada. The basic funda behind this study was to just remove the trophoblastic and the fetal tissue, not allowing to disturb and destroy the other part of the uterine cavity, and maybe it might lead to a better future pregnancy outcome and might prevent Asherman syndrome. So with time, with modernization, our scope size is decreasing with time. There was a time when we were using a very big scope. Now we have decreased to mini hysteroscopy. So I would like to, in your practice, what instrument to use, you should decide upon. It is a single use, so is it comfortable? How many patients you have? Can you use it or not? Delicate handling and price affordability. So take home message is old is gone. Is it really so? Old is gone? I would like you to decide yourself. There was a time when our grandparents, their parents used to see their partners, and they could never see their partners before they get married. But nowadays we believe in seeing and treating, like similarly, like we would like to see our partner before we we become full partners. So it is similarly like that. So would you like to proceed from your blind procedure to your modernization technology, that is see and treat? The choice is yours. Thank you so much.
Thank you, Dr. Ramina Akangum, for your nice presentation. You already pointed out all is gone. So decision is yours. So we have to think which patient, which type, which can afford, which cannot afford. In that way you can continue. But with the advancement of the infrastructure, with the advancement of the skilled surgeon, I think it may be within our audits in such procedure. Thank you.
Thank you, chairpersons, and thank you, speakers. Now I would like to call on Sir N. Shubodha, sir, to felicitate the first speaker of this session, Dr. Anuradha Panda. Please come on stage, ma'am. Let's give a round of applause. I would like to call Chairperson Dr. C.H. Mandle to felicitate the second speaker, Dr. Rangina Laikambam from Kathmandu. Let's give a round of applause. Thank you, chairpersons. Thank you, speakers. Moving on to session 5, guest lectures. I would like to call on stage Dr. K.H. Tomba, Managing Director of Maipakpi Maternity and Child Hospital, and Dr. Santa Singh sir from Shillong, Dean Nagrin Shillong, to chair the next session. I would like to call on stage Sir Santa Singh, Dean Nagrin Shillong, to chair the session. I request Dr. Digil Sharma, Organizing Secretary, to chair the session in absence of.
Thank you, the organizers. Now it is already late. Now we are taking up the fifth session. First of all, I would like to invite Dr. Tusharkar, Kolkata. Huh? Oh, Basant Mukherjee. Okay. Dr. Basant Mukherjee from Kolkata. He will be delivering the talk on dilemma in preterm labor. Okay. Yeah. So, Dr. Basant Mukherjee, please. You all know that Dr. Basant Mukherjee, he has come here in Imphal many times for the organization of this since today's meeting, and he has come many times and he has given lots of information and help guide to our IGF member, and so he will be delivering this topic, dilemma in preterm labor.
Thank you, respected sir. After two very interesting operative sessions on robotic and hysteroscopy, we come back to something which is more mundane but more close to our heart, obstetrics, and in obstetrics, dilemmas in preterm labor. So over the next 10 to 12 minutes, we'll take you through some issues about prediction of preterm labor, prevention of preterm labor, what we know now, antenatal corticosteroids, where we stand, the magnesium sulfate, some delivery issues, early neonatal issues, and long-term issues. So just starting with one of the things, dilemmas in prediction. I think there is fair amount of understanding that in the history, if you have a history of preterm labor, then there is a very high chance of the next pregnancy to also be a preterm birth. But there is also a lot of knowledge which is not known, especially for the index pregnancy which may have a preterm birth. Cervical length, we have good understanding that if the shorter the cervical length, the more is a chance of a preterm birth, especially less than 25 millimeters. Some people say 20, some people 15. And so charting out cervical length in a patient who already has a history of preterm birth sometimes is one of the best indications. Fetal fibronectin we have heard for the last 20 years from our postgraduate days, but at the same time we do not use it much in clinical practice, and there are other biochemical markers which are coming up both for detection of amniotic fluid, that is the leaking, and also for preterm birth. So that was the dilemmas in prevention of preterm birth. I think there are two things which you mentioned. One is the progesterone, and one is cerclage. So I think those are the two things which have come up in prevention. And so let's focus on the things which we are having a discussion on. So the progesterone which you use for preventing preterm labor, one is 17-hydroxyprogesterone, one is vaginal natural micronized progesterone, and the gel, of which we don't use the gel so much, but we use a natural micronized progesterone. And 17-hydroxyprogesterone, there's some updates recently which we would like to share after the results of the prolonged study, where it showed that it was not of much use in the prevention of preterm labor. About cerclage, we'll just come to a few slides on cerclage, about history indicated cerclage, ultrasound indicated cerclage, and etc. So progesterone, as we understand, in preterm labor should be started as early as 16 weeks. If you're giving it to a woman who has had a previous preterm labor and has come to you again in the first trimester or later, then you should start as early as 16 weeks to make a difference. Still some time ago, we had two options of progesterone. We still have two options of progesterone. One is the 17-hydroxyprogesterone caprate, which is given as weekly injections for between 16 to 36, and one is the vaginal micronized progesterone capsules, which you give as 100 milligram daily, twice daily doses, sometimes or daily doses, and that's over time. So what happened in April 2023, we know that the US FDA had withdrawn the approval of 17-hydroxyprogesterone as one of the methods of prevention of preterm labor. And the reason why they did it is because of the results of the prolonged study, where it said that no, it's not of any use. It is it does not make sense of using it. And that's something big, because till now we had two, now we have only one option of vaginal micronized progesterone. This is not a slide which you can see very clearly, But the cerclage is another thing. A lot of people don't talk about cerclage in the sense that it's outdated. A lot of people think that don't do much of cerclage in their clinical practice, and there are some people who swear by cerclage. Sometimes in our clinical practice, we see people who have an IVF and then have cerclage, people who have a multiple pregnancy and then have a cerclage, none of which are evidence-based, but there are a lot of people who love cerclage and to do something for a patient. So there are three things which we mention and discuss in cerclage when it comes to the dilemmas. One is history-indicated cerclage. So history-indicated cerclage is when there are 3 or more previous preterm births. And now a lot of you may ask, why do you wait for 3? Why don't you do it after 2 or even after 1? Well, that's not shown to be clinically, the evidence is not for that, for to do it earlier than that. But if there are 3 previous preterm births, as a history indication, you can definitely have a cerclage done. The ultrasound indicated, as I said, it's less than 25 millimeters. When it is seen less than 24 weeks, and again this is done for a woman who has had a history of previous preterm birth. So if it's a person who's not had a history of previous preterm birth, you're doing an anomaly scan and you just want to see how the cervix is, and it is not it's a short cervix, then I think even then there is no indication of doing of giving progestogen or doing a cerclage, because there's not much of evidence to say that the incidental finding of a short cervix would cause preterm birth. Cerclage is not indicated, as we mentioned, in cases where it is an incidental finding or where it is found by accident. So it's not and especially for a person who does not have a previous preterm birth. Coming to antenatal corticosteroids, I think this is one of the most commonest drugs used in clinical practice when a preterm labor is mentioned. And there is enough of evidence to understand that between 24 to 34 weeks it is obviously needs to be given, and the numbers needed to treat are low, and the benefits far outweigh the risks, and it must be given. If it's below 24 weeks, then you really have to think about it, whether it's worth salvaging that baby, and the parents have to be counseled about the long-term complications. If it's after 34 weeks, then again it may be considered in some patients, but again that would be a case-to-case basis, and your numbers needed to treat is much more. So in antenatal corticoids, we talk about betametrazone and dexamethasone. Often some people are used to one, some people are used to another one. It depends on the availability. But the only 2 top points of discussion are the betametrazone, the salt which is available in India, is not the salt on which the initial trials were done. And dexamethasone, the dose which we have in India, is not the dose which you need. So the 6 milligrams which we give, the actual 6 milligrams is what is required, but the dose is I think 8 milligrams which we have here. And betametrazone, the salt is different from what we have. So there's not much of evidence to show one is better than the other. So sometimes some people are used to one, some people are used to another one. There's no additional benefits of accelerated dosing. Sometimes when a woman comes in with threatened preterm labor, you would like to give the doses of betametrazone not 24 hours apart, but 12 hours apart or 6 hours apart, and you want to finish it off first, but there's no clinical benefit in any evidence. So besides respiratory distress syndrome, there's a decreased incidence in death, intraventricular hemorrhage, periventricular leukomalacia, and necrotizing enterocolitis. And there was once thought to have the chances of infection to be increased, and that we have, it has been shown over time that is not the case. So moving off from antenatal corticosteroids to magnesium sulfate. So magnesium sulfate for neuroprotection. I think this is something where we do understand that magnesium sulfate is very important in neuroprotection, and now there is enough of evidence over the last 10 years to suggest that in a case of delivery, imminent delivery between 27 to 32 weeks, it must be offered. And it has various benefits, and the main idea is to reduce the chances of cerebral palsy. And the dose recommended are it's like the Zussman regime which you use for eclampsia and impending eclampsia, where it's 4 grams given IV bolus over 30 minutes followed by 1 gram per hour. And the new thing which has come up, there's a company outside who has 4 gram doses already premixed. So now you don't need to really understand what dilution to use and what to do, because now they have 4 grams already there. There's insufficient evidence for a repeat dose except for in a case of a magnesium sulfate. So there are a lot of trials to suggest it's being useful. The next is antibiotics. In antibiotics, I think what we need to say is that if the membranes are ruptured, you have a option of giving antibiotics, or if you have gross infection where she has coexisting UTI. So we know, all of us know, that in preterm labor, one of the starting points is an infection or inflammation, and that is something where antibiotics may be offered. But again, there is little evidence to suggest with intact membranes that does make any sense. So in PPRN, if it's erythromycin is what is the preferred choice, and not amoxiclav, which has a more NEC risk. And antibiotics have no effect on the other things. The other thing to discuss in preterm labor when you're talking about dilemmas is tocolysis. And tocolysis is something which a lot of us have grown up with in our MBBS days, in our postgraduate days. Later in life, you see tocolysis of various types. So we have all, I think, 25 years ago in our college, we started with nifedipine. At that time, nifedipine was number one, and still possibly is. And that time, and atosiban, of course, we keep on hearing about it, but with little experience personally, and with little experience, not much of trials there. Okay, 10 minutes to bell rang. That's wonderful, I think. But I think we could make it 5 minutes also. I think we can stop it now also, but I think it's not fair for everybody else. We should start running the bell from the morning. So the important thing of the bell ringing is that it should be ringing from the morning and not ringing in the afternoon when you're already running 2 hours late. So I think that's an important thing. I think the next message, very important points, is whenever you have a program, you must start on time and end on time, and that is a discipline which in India we lack, and that's something which we really have to learn and make ourselves learn. We try to do it in every conference, and I think that's a very important learning point. It's not important to get bell bajao. It's more important to just start bell in the morning. Don't start bell in the evening. Start programs on time. Make sure 8 o'clock we start. As 1% of the audience start. That's not what you do, and then in the evening you start bell. So dilemmas in delivery issues, vaginal delivery versus elective Caesar. So if it's a preterm baby, if it's a preterm breech, would you have a vaginal delivery? Would you have elective section? A tertiary care center setting, if you don't have an ICU setup, of course you need to transfer, and there's new thoughts about whether tocolysis is at all important or not. So once upon a time, the last few years, our thinking is you have a tocolysis good enough for an in utero transfer or for steroids to act, but nowadays people are thinking whether that also is good enough for tocolysis. Early neonatal issues, something which you already know, are RDS, IVH, NEC, PDA, retinopathy of prematurity, and long-term issues. I think one important thing which all of us do not do routinely, but we must do, is when a preterm birth patient is coming, who is in preterm labor, who is going to deliver quite soon, is a discussion of the family, at least with the pediatrician, because they have given an idea about how long, what the short and long-term complications would be, how long the ICU stay will, how much it will be increasing. Last, I think I'll skip this and we'll go straight to the takeaway. The several dilemmas exist in managing preterm births. Prediction and prevention still remain the key goals. Antenatal corticosteroids and magnesium sulfate are to be used in cases of impending preterm birth. Several issues around delivery is not clear. Immediate postnatal and long-term issues need to be addressed. I have two submissions here. One is conferences in Kolkata. We love to do conferences, all of you know. The AICOG 2023 is in front of you, but of course there is more action in 2024 happening in Kolkata. In February, our second weekend, we have the IAG endoscopy. So that if your endoscopy interest, that's Endogyne 2024 for you, under the aegis of IAG. In April 19 and 20, we have a FOGSI and SFM conference called Fetal Vision. So if you're interested in fetal medicine, that's a place where you should need to be, April 19 to 20. There's a FOGSI conference under the presidentship of Dr. Jaideep Tank. It's called Wisdom, and that is it's like a mini ICOG, and that will be June 21 to 23 in ITC Royal. And the Royal College Conference, which has a lot of academic value, which is under the aegis of AICC-RCOG, is happening in the third weekend of September, 19 to 21 ITC Royal. And the last conference of the year there would be the Bengal Society, the All Bengal Society, where the districts of Bengal will join with Bengal, with Kolkata, and that will be in the December 27 to 29. And the last submission is a prayer for all of you to support my elder brother Dr. Bhaskar Pal. He's standing for the president of FOGSI, and don't support him because he's from the East Zone. Only support him if you think he's the best for the position. Thank you very much. All the best.
Thank you, Dr. Bhaskar, for your nice and interesting topic, which is still having the dilemma for the treatment purposes. So, any comment, anything from the floor of the House?
No question.
Yes.
No question. No question.
I just want to know, what is your experience regarding strength and quality of evidence between antenatal corticosteroid and the artificial surfactants from nebulizer?
Once more, Dr. Anderson. I think you asked me a question on antenatal corticosteroids versus surfactants. Versus surfactants means if I think what you mean to say is, if you give antenatal corticosteroids fairly religiously, would that decrease your use of surfactant? That's number one. Or if you have surfactant in spite of giving antenatal steroids, whether it makes a difference. So the experience from our pediatrician colleagues who come back to us saying that what you did was good, you gave steroids, it was just 6 hours, but still was 6 hours is wo bhi useful hai. So that is one thing you hear from our pediatrician colleagues. The thing that even if you need surfactant after giving antenatal corticosteroids, it will be less. The RDS would be of a lesser severity, and her need in ICU stay would be less. So it's very much for, I don't know, we don't have studies on how much money, exactly how much, but the clinical experience or the feedback from our pediatricians is err on the side of giving antenatal corticosteroids than not giving. Give more. I will not be able to tell you, sir, that I'll have to come back. Thank you, Dr. Ranjit. That's next time I'll definitely come back.
Next speaker is Professor Dilip Kumar Datta from Calcutta. He is a well-known and a well-experienced doctor and associated with IMA, FOGSI, and many times, most of the conferences he was there. He is the one representative from Calcutta to the FOGSI. And so his experience he will be delivering to us. So Professor D.K. Datta, please.
Thank you very much, sir. It takes me 13 hours from my place to here to give the talk on 10 to 12 minutes. I finished before time. Today I talk on mainly placenta previa, accreta, incita, percita. What is my experience? I am not going to detail this one. You have to be very careful, because this time I went to the Paris. What I have seen, today I will talk this one. This is Hanoi. Then South Africa, they have done a lot of work on placenta previa. This is some slide. I'm taking from Paris. They are doing the hysterectomy in all cases, and somewhere they are doing they make the kept in situ. That is till today in the world Congress I have seen in the Paris. Now when we talk to the placenta previa, we have to know the degree of placenta previa or type or level. We should exclude the vasa previa. This is important for us. Now, till today, we have to manage in the proper way in the good hospital, mainly in institutional delivery. But bad luck or good luck for me, I work in a rural area, and my experience shows what I am telling today. The basic principle we know very well. I am not going to detail, because I told you I'll finish within 12 minutes. Management means place, time of management, time of delivery, very important. And then problem faced during CI section, this is very important. Now I am talking only placenta accreta. I am not talking now placenta inferior perfidal palm later on. You know, these are the problems we are facing when we are going for during cesarean section. Till date, many existing methods, what they have done, I heard since morning that they first you deliver the baby first, then they try to remove the placenta, and if there is a bleeding, they are doing the oxytocin, other things, or they are doing like this. My question is very simple. Our woman is very much anemic. Why you do this way? I am coming to you. That this technique, many places they are doing it. That leads to the complication. Disease is a complication. Our patient is very much anemic. Now most cesarean section down everywhere. Incidence of placenta actita is rising. So who is responsible? This one we have to find out. Now in the FIGO 2023, this is the paper they published in the FIGO. I have taken this one. None of them has developed a new technique which I have done about the 20 years back. They are coming to you now. This is some of the picture in the FIGO. I am not going to detail this one. I captured everything in the FIGO, what they have done and what my country is doing. This is some of the picture. This is doing the hysterectomy. This is some of the method. Now, the various intraoperative surgical techniques done, still they to prevent PPH. When the PPH is there, they develop many techniques. The technique of this one starting from, just see, in 2014, myself developed my technique which is published in the journal and followed by Billings technique, completion Fisher in 2016. Now what is my techniques? Very simple way. You have to know the anatomy very well. It is an anatomical bleeding which cannot be controlled by your drugs. So you have to tie the descending branch of uterine artery, that will help you. So you know the anatomy properly. After anatomy, you should also know the bladder injury prevention is very much important. Now what is my technique? Very simple, just see. I first deliver the baby first. Then I ligate the descending branch of the uterine artery. If not possible, addition is there, ligate the ovarian artery both sides. When you ligate it, perfusion pressure will be less. Then we will give the oxytocin and other drugs to make the upper segment contracted. Then when it is okay, then I try to remove the placenta. So my option is very clear. We take the baby first, then ligate the descending branch of uterine artery, then give the pemetric acid, then try oxytocin, make the upper segment contracted, then try to remove the placenta. You find that the bleeding is very less as compared to the technique I show you. My intention is very clear. If the woman come to me as a primary gravida, or if the pregnancy come to me even multi-gravity of no children is there, why you remove the uterus? What is justification of this one? So this is my technique. And now this is because the time is I told I will finish this one. This is the video, just here. Not to worry, because already I ligate the both sided uterine artery, descending branch, no bleeding is there, not to worry. Just see, and it will come very easily. That was done in 2013. Now, what we do after that, if there is a bleeding is there, I try to do the interrupt suture, along with I put the gel foam in between the incision line so that there is no oozing. Now if you put the gel foam inside the incision line and then you interrupt the suture, it will help you. So this is what we have done. No bleeding is there, nothing is there, and it is published in the JMS journal, Major Placenta Previa, 2013. Now tell me, in the Paris, it is now as of till today, they have not adopted my method because I am from India. There is a problem. If somebody is doing the billing, a billing. In my life, I have not done any billings. I have done a lot of delivery in my place. So, and then comparative study, we make it is come by another journal, novel approach to prevent the postpartum hemorrhage during the LUCS majority. So, this is a comparative study, it published. Now, this is operative findings. You find it. You find that maternal mortality nil. Morbidity is there because I am working in the Kalani near the Bangladesh border. People is coming like anything, and with no history, nothing is there. And then fetal outcome, post-work follow-up, then post-work follow-up 7 days. Then this is now I coming to the very simple way of how can treat the patient in theta and per theta. The special situation how to diagnose this, I am not going to details. So what I have done in theta per theta, I make the two, partial and complete. Please understand my point. Partial means for the posterior incision line, it is a in theta per theta, other area it is a ectheta. So during cesarean section, if they go inside the incision line, is in theta per theta that area, but other area is ectheta, diagnosed by MRI or complement totally complete. Now I developed this method to teach the student, to see the doctors work in the rural area and see this is a very easy way how to do it. That is it, we want it, and that is our main idea. Again, I am sorry to inform you, even if I write to the FOGSI, you start my method, but I am happy to say that Government of India, for the IMA, they wanted to do it. That is the thing, we spread. If we do it, why not you will do it? If they accept it, let's see if it is good or bad, they have to be done it. Then, not worry with the management. They have what a management? The fundal incision with, this is a partial. Now, embolization is there, my technique, doctor's techniques, last removal the patient. That means for the incision line, that area I will remove. Because I take the partial, means for the incision is a incita, parcita, other is a crita. So if I remove this part only along with the, it will happy, then I can stitch it. But if it is a complete, my vision is that because I am working that place, if the patient dies, he will come and beat me like anything. To save myself, so I have done this method in kept in situ. At least at that point of time, he will not touch my body. And that is the thing, you have to do it. It is not that you do the hysterectomy, I am doing the hysterectomy, or you see the patient coming with the bleeding. It is an anatomical bleeding which cannot control immediately, then the patient will be cut. And that is what I am telling before you. This is the hysterectomy. Then my experience, I have done only 7 cases, I have done it, only kept in situ, and that is what is my observation. It is not that I am telling you before you, this is my observation. Recently I am publishing another one also, completely within the 15 cases we have come to my area. This is the thing. So in conclusion I said it is a simple, safe and quick procedure, easy to perform, and less complicated, permits time for further step, the perfusion pressure is reduced. That is very important. I have done the hysterectomy, Hanoi, people say that. Sesok said that it is better if you kept like this. That is the problem for us. That is why I went to Paris, observe everything. And that is very important. So to prevent unnecessary hysterectomy, I planned all these things. And Billings is great, my friend. He came to Kollam, see my work, he nominated me, and it is important. When I see the patient is dying, they are crying in the rural area, no blood, nothing is there. What I do? In the institution, I am not deadlocked. I am not work in an institution. I work in the primary health center, rural area, then subdivision, then retire. That is the problem, and that is you have to fix it. So accordingly, I make one song. This is my last song. This is I think I feel no. This is I made it because people are trying. Yeah. Come on. Volume, no? There is a problem, you know.
Directly.
So, person is breathing. Do it. That is. Acha. Yeah. How to? Wait. This is very important because why I'm telling you this, I make it a Bengali, Hindi. Now it is coming. This is a song by one of my we are believer. Why I'm coming? He will do it. Just see it. Know what I've done.
You will sing or you will sing?
No sound. Whatever might be this song, very simple song I'm telling you. It is not a song poem. Oh mother, where you are, searching you everywhere. You left me after my birth, heard that you died due to the loss of blood. Oh mother, where you are, searching you everywhere. With your DNA, and now I am become doctor. With my innovative work, I will not allow any mother to die due to the loss of blood. No child will lose their mother. Oh mother, where you are, searching you everywhere. After completion of my work, again I will go to a place and sleep under your lap forever. Oh mother, where you are, searching you everywhere. Even if you like this, then you can say all the mother and mother will
Chairman,
thank you very much, sir.
I am a standing committee initiative. Thank you very much, Dr. P.K. Datta, for your
has developed many methods to prevent the hemorrhage during pregnancy and during delivery. Today, I am releasing the poem in three different languages, one in English, Hindi and Bengali, to highlight the importance of the hemorrhage. So, thank you, sir. I think I finished before time. I wait 19 hours for that. Thank you very much.
Thank you, Dr. Datta, for your nice presentation and especially for taking the whole role to the mother. And for the mother's sake only, whatever we are doing is there. But one and any other topic, any other place. Only problem is whatever we have discussed today, what I want to say is preventive measures is the best one, and whatever the problem for the juniors who are going to deliver babies in their own nursing home or in their hotel bodies, you select the high risk pregnancy. If there is a high risk pregnancy, try to take some time and take the help of some seniors or whoever is there so that the results be good. Dr. Malone.
Dr. Datta, one question. You have put the, you have take out the uterus when you are in rural setting. From rural setting, you have sent the patient to Ifita, keeping inside and sent to urban center. Or do you in urban center? You do hysterectomy over there.
You are absolutely right. You are absolutely right. What I feel, I told you, in my area, I work in that area with my assistant, you know it?
Yeah, I know.
He's a sweeper.
Okay.
I'm telling you, it's a practical. In West Bengal, in some district and primary health center, practical. To save myself, sir, is the best method, I think.
Okay.
Because in 7 cases, what I have seen, nothing will happen. If anything happens also, after 7 days, you will keep quiet.
Because my
Secondly, sir, your hysterectomy, nothing. I can do a lot of hysterectomy, no problem. Why you do it so much enemy? Okay. What is the reason at that time unnecessary bleeding?
Because I'm asking you this regarding 2 to 3 cases of your placenta previa detected at mid trimester, low lying, and anterior, sometimes posterior, and then from the ultrasound findings seems to be placenta epita. But keep on, monitoring it, in other hospitals where in the Jennings, where I also work at the contract basis after my retirement from here. But in midnight, patient from the labor, and then our resident, what they did is that in part of the case, it was diagnosed as a low-lying placenta, seems to be a papita. They cut in the lower segment, take out the placenta, that is heavy bleeding, leading to massive hemorrhage, and then amounting to about 10-15 bottles of blood, and doing hysterectomy midnight. So on that occasion onward, I told them, if it's suspected in such way, prior diagnosis, then you have to cut it in the longitudinal section opposite, and like if CS, take out the baby, put the placenta in, suture it again, and do the hysterectomy again. Then in that case, we need only 1 bottle of blood. This is on 1 or 2 occasions.
Now, only that incision I want to tell you one thing, sir. Before cesarean section, I always tell the radiologist, please show me the upper level of the placenta. So upper level of the placenta means you have to give the incision of the upper level of placenta means you will not injure.
Yes.
This is very important.
Thank you, Dr. CM, because this is a really practical problem. Only those who are handling and tackling the situation to realize. So experience counts for this only. Thank you, everybody.
Thank you so much, sir, for your enlightening presentation. I would like to call Dr. K. Shobha Singh, sir, and Dr. Divya Sharma, sir, to kindly felicitate our speaker for this session, Dr. Basha Mukherjee and Dr. Dilip Kumar Datta. Thank you, speakers, and thank you, chairperson. Next, moving on to the next session number 6. We'll call the chairperson for this session, Dr. Saswati Sanyal, Professor, Guwahati Medical College, and Dr. N. Jitendra Singh, former professor at the Department of OBGYN RIMS, Imphal, to kindly come up on stage and chair this session.
Good afternoon, everyone, and it's my privilege to introduce the first speaker of this almost last session, I believe, and he's none other than Dr. J.B. Sharma, and he's well known to all of us because I think because he belongs to AIIMS Delhi, and he's also ex-professor of Maulana Azad Medical College, New Delhi, and he has his book, and I think most of the postgraduate students read his book. And he was awarded B.C. Roy Award by Honorable President of India in 2015. He has more than 350 publications, and he is the editor-in-chief of Obstetrics and Gynecology Today, and won Indian Council of Medical Research Amrit Modi Nikem Prize for his research work on anemia during pregnancy, the most important killer of our country. Okay, yeah, I think we should start on this topic of surgical management of SU.
Thank you, respected chairperson ma'am, for the kind introduction, and at the outset I thank Imphal society, especially Dr. Ranjit, my personal friend, Prasanta Singh, and all the whole team, Pratima and everyone. I'm sorry if I'm missing some names, for inviting here, and my wife has also joined me. It's a most wonderful opportunity to visit the city, and thanks for the personal basically attention to all of us. So thank you, ma'am. And sir, I got Dr. B.C. Roy Award. You said no, Bengal is rule Bengal. I mean, most prestigious award in medicine is Dr. B.C. Roy, who is Bengali, sir. So I mean, I think Bengal is the most advanced state of the country. Yes. Thank you. So. So my topic is basically urinary incontinence, and for the postgraduate there are few. So we know that bladder and organs, I'll be quite fast. So we know that bladder is a storage organ, and excretion of urine is the main thing, and these are the sports of the uterus basically. So the sports of urethra and bladder. So levator muscle and the pelvic fascia, arcus tendinous fascia pelvis, and then intrinsic sports are also there, like striated smooth muscles of urethra, epithelial cooperation of the urethra, and tone of urethra, elasticity, congestion of submucous pressure. So intrinsic sports are very, very crucial because the childbirth trauma occurs at age of 25 to 30 years, which causes damage to the endopelvic fascia, levator and eye. But the patient may remain continent at that time. She may manifest at the age of 40 years. So how is it that she was damaged at 28 years but manifests at 40 years of age? So that is because of intrinsic sports like this mucosal cooperation of urethra and congestion of some mucous flexure take part, and when at 45 or 50 years of age like estrogen levels go down, so this intrinsic sports go down. So the damage occurred before, but so the both are basically very helpful for the patient, and that is the role of them. And this is the hypermobility, and it can cause because of trauma. I'll be coming to that also. So urinary incontinence for the postgraduate, basically any complaint of involuntary leakage of urine according to International Incontinence Society, or as per ACOG, basically this of involuntary loss of urine on effort, physical exertion, sneezing or coughing. So that is stress urinary incontinence basically. So just for the postgraduate, any raise in abdominal pressure, right, makes the patient to leak urine, then it is SUI. Like I'm telling the joke, everyone laughing excepting one, then it is SUI, isn't it? If someone has to go and she cannot control, then it is urgent incontinence. So I will restrict my talk mainly to the stress incontinence. The grading is just like NYHA classification for heart disease. So grade 1 mild, 2 moderate, 3 severe, and grade 4 very severe, or even incontinence even at rest basically. So that is what to simplify the thing basically. Prevalence is low in young women, but as age advances, prevalence go high. But I think we are living a little bit in a fool's paradise. We think it's not an Indian problem. It is very much Indian problem. Only thing, many of our women, they suffer in silence. They don't come forward. I mean, there's this actually sad thing that if a patient has got chest pain, she will immediately rush to the doctor. It can be MI. If someone has got bleeding from any orifice, they go to the doctor thinking it could be malignancy. But if she leaks urine, then she talks to her maybe some elderly woman in the house. She also has leaking urine. She talks to some neighbor in the house, in the neighbor, leaking, and then she go to an elderly animal, she may also leak. So they think it's a part of normal aging. So this is not actually, it can be helped. So that is what I want to highlight, that please do help the elderly women. We can help them a lot. And incidence is quite high, almost 45%, even in India it is high, and nearly 77% have positive symptoms because of SUI, and as age advances you can see all types of incontinence increasing. So we did a study, Lina was a professor now, so we found out 8 to 9% in daily clinic at that time, and then Shana Gurwal, she was our medical student, again for the medical student, even at a medical student 8th semester level, she did a small study with me, and can you imagine, I mean, now she ultimately didn't pursue medicine, she gave IAS exam, she topped in IAS, she is a commissioner in Punjab now. So what I want to highlight, even as how medical student level you can do a small project, which can be published to Archives Gynae Ops, which is a PubMed index from Switzerland and Germany. So we found, I was surprised that 19% patient in second trimester and 22% in third trimester of pregnancy had SUI. And these patients did not complain to me about it. But when we asked them direct questions, then they came up to it. So it came as a surprise to me also. Not that we did anything for it, it's just a part of pregnancy because of pressure effect, and many times these patients after delivery they may become all right also. But just to, I want to highlight that how you can do plan small studies in your setup and can get published also, and we can have the Indian data also now. That was the importance of this thing. So we all know the risk factors for basically childbirth are the single risk factor, the childbirth trauma. Okay, so pregnancy is generally the significant risk factors, but of course having said that, though theoretically we can say that cesarean section prevents urinary incontinence and prolapse, but considering that just to talk by Dr. Datta, previous cesarean section is a single most important factor for placenta accreta past spectrum, which kills so many women and such a difficult thing. So we cannot recommend cesarean section just to prevent SUI and other conditions. But I mean, and even after I have seen, I did a tape procedure for a patient who had previous 2 cesarean, never a delivery. So SUI can develop in spite of, without, I mean, even after cesarean section. So just some reduction is there. Plus the pregnancy itself, because it causes relaxation of the ligaments and all. So pregnancy itself also, makes her more prominent for that. So cesarean section is not to be done to prevent SUI or prolapse. That should be clear to everyone. Then there are certain factors like caffeine, fluid intake, they can cause urge incontinence, certain medications, constipation, condition affecting mobility, medical conditions. So why I want to highlight these things are that when you are taking a history of his SUI patient, urinary incontinence patient for the postgraduate and SR, it is very, very crucial. Please spend some 10-15 minutes with her. Ask her detailed history. Many times when we get patients like, patient complaining, including our gynae colleagues, my one gynae professor, she brought her mother to me, Dr. Sharma, look at my mama. Mama lie down. So mama lay down and then she said, Mama cupped and there was parabola of urine. And she said, Dr. Sharma, just put a tape in her, you are good in putting tape. I said, no, let me examine auntie. So she had 600 ml in her bladder. So even a gynae consultant missed her own mother. She wanted me to put a tape in a patient who was overflow incontinence. So I think for our own mothers, we get a bit biased probably. Similarly, another patient, she had neurological sequelae. Our professor, head of microbiology, she got her mother admitted, even arranged tape for me. They said put these things. She didn't show the patient to me. I said, no, let me examine her. She had neurological problems. So I didn't do that. So it's important. I mean, then some patients are taking too much of fluids. There is this concept going on, if you drink too much of water, we become beautiful, our face will glow like Manipuri girls, or Katrina Kaif. So please, effect of water on face is doubtful, but effect on blood is real, they leak urine. So just by reducing the fluid amount intake to 1.8 to 2 liters, we can reduce the amount of urine, and many patients became alright just by reducing the fluid intake. That is also important from history taking. Then these our cardiologists and physicians are very fond of giving diuretics for hypertension. That is essential. So just by changing the diuretic to another antihypertensive drug may make them to pass less urine. So this is very, very important. Then patient may be diabetic. Again, diabetic patients have a tendency to have. So it's very, very important. One of my patients had. She had some loss of sensitivity in this area, and when I took a detailed history, she was unmarried dentist herself. She was born with meningomyelocele, so she was operated in childhood, and now she became a doctor. I was so happy that and then she had this problem. So I mean, the tape is not answer for that. So that was a neurological condition. Some of my patients have multiple sclerosis. So why I want to highlight, please do take detailed history of these patients. It's very crucial, because just by changing the medication, just by treating the original medical condition, neurological condition is very, very important, rather than just jumping to the surgery for these techniques. So that's very, very important. Okay, and then so detailed history taking is very important. I mean, again, full detail, how often, how much aggravating improving factors, use of pad, effect of symptoms, the quality of life, and storage symptom frequency, nocturia, etc., voiding symptoms. Then, as I told before, past history, any diabetes, any pulmonary disease. Again, neurological, respiratory, pulmonary disease. This is important because chronic constipation, raised intra-abdominal pressure, chronic obstructive airway disease. I was referred a patient by my consultant colleague from Delhi. So the patient had hysterectomy first, madam. Then she had wall prolapse. So wall prolapse surgery was also done on assistant fixation. Again, it failed. So I said, how it is happening that in 7-8 years she had 2 failed surgery. So I took detailed history. Patient had chronic obstructive airway disease. So I refused to operate on her. I said, first to get it under control. I referred to Professor Jubilee, our HOD and director. So he got her under control. I mean, we couldn't cure her COPD, but it was under control. Then we did abdominal cephalopaxy for her, and it's for 8 years now. She is in totally fine. So had I done the operation without treating her COPD, I would have also failed, and they would come to my surgery. So it is important, not only it's important for the etiology, also important for what surgery we are offering them, so that we can have optimum outcome for our surgery. Similarly, chronic constipation is becoming a big issue, madam. So many, every alternate patient I do PV, their rectum is loaded with people, and they don't even know about it. So this is important to treat their chronic obstructive airway disease, chronic constipation, or any raised intra-abdominal pressure, so that our surgery doesn't fail, and sometimes they may not need surgery. Just by changing that, just by giving treatment for constipation by exercise, I won't name, very, very senior ex-professor had came to me, from one of the states, I won't name, and, very dominating and all. And then she had rectocele, and I told her, so by doing good exercises and, and by controlling, she had, constipation unknown to her. So by treating her on Dufalac, electrolysis, plus by physiotherapy. I examined her again. I said, madam, I can do operation on you, but not really needed. Maybe by exercise, and at this age, she was 85-year-old, some comorbidity. So then, and after 3 months, I saw her. So when I put my finger in PV, she squeezed my finger so hard that they hurt. So by just by making good perineal muscles, she could control her this thing. So it's important that Kegel exercises, chronic constipation treatment may avoid unnecessary surgery many times in these patients. So that is very important. It's neurological disease, as I already told you, pulmonary disease, and then drug history, like some patient being on benzodiazepine, antipsychotic, anticholinergic drugs, and past history of treatment of incontinence and menstrual obstetric history, of course. Okay. So same way abdominal examination, I have seen 3 or 4 patients when there was some retroperitoneal mass, it was pushing everything down, including uterus and all. So patient had prolapse and incontinence because of that. So that is important. We had to remove that. So similarly, or hernias or distended bladder. Then on examination, excoriation, prolapse, atrophy, tone of pelvic muscles, demonstration of leak, cup stress test, bony test. So these tests will be showing. And then I told you already, neurological examination normally we don't do in a gynae obs case, but in this patient it's important. And then of course urine analysis just for any urine microscopic and culture, because UTI symptoms and urge incontinence symptoms are same. So for the postgraduate, urge incontinence is symptoms of UTI in absence of UTI. Urine culture is trial, but patient is having nocturia, frequency, urgency. That's so important. And then of course sometimes post-voidal urine, cystoscopy, MRI, CT, X-ray not done for routine cases, only sometimes we have to do it. So again, approach to a patient, you can do a pad test as a part of thesis. My PG did it. So we make them to wear a pad, and we wait before, and then we give them, the patient can drink some water. She walks for about 15 minutes, and then we weigh the pad again. If there is more than 1 gram increase in size of this thing, that means patient is leaking urine. So dye test is usually done for VF, etc. Bony test for all the postgraduate. Patient is lying in the lithotripsy position. We stand on the side of the patient. Never stand in front of the patient. Otherwise, when she leaks urine, your clothes will be wetted quickly. So, or put your 2 fingers parallel to the urethra on either side. Ask the patient to cup. She leaks urine. When you raise them, then cupping, this leaking stops. So that is Bony's test. So that will also tell that Wirtz corpus suspension is going to be effective for her. Miyazaki Bony test is, instead of using finger, we can use 2 sponge holding forceps. So it is more in line of the basically Wirtz corpus suspension. Cavitative test just show the more than 30-degree hypermobility. Pediatric poly test just like is just like cervical insufficiency test. When we would the cervix is incompetent, same way urethra is incompetent. This is seen in case of interinspirated deficiency. So use it, but number 8 poly, can easily come out through their urethra. But usually we avoid it. And micturition diary, you just a weekend diary. 48 to 72 hours diary. This is important. I told you 5 patients I treated. Just they were drinking 3.5 to 4 liters of water or some drinks. So just by reducing their fluid intake to 1.8 to 2 liters, I have treated about 8 to 10 patients without any surgery, without any medication. Okay, so the urodynamics are not normally indicated for a average patient. American College also says that you don't need it. Only for if it is straightforward a SUI patient, you can do surgery also without urodynamics. Urge incontinence patient in any case need only medication treatment. So no need of urodynamics, but in complicated patient, failed surgery or difficult surgery, then only you do it urodynamics. Otherwise ACO also says so. And then we can do uroflowmetry, you can do multi-channel cystometry. I won't spend time on that. So one basically catheter is put in the bladder and urethra along with the is the fluid also intake, and then another transfusion is put in the rectum for the intra-abdominal pressure. So that's why we do this technique. So during basically grossly during filling phase, they should not be the bladder should not contact. If it contact, that is that to the overactivity or urge incontinence. For SUI, usually patient leaks urine, so it's so much visible otherwise also, and then we can do this channel cystometry just for the postgraduate. Residual urine less than 50, these days up to 80 ml is also taken normal. First desired to was 150 to 250 ml cystometry capacity bladder for 400 to 600, and these are the pressures, peak flow 15 ml per second. In the management, urge incontinence, stress incontinence, some managements are common. Lifestyle changes. Ask her to lose 2 to 3 kg weight over next, next 3 to 6 months. That helps. Then pelvic floor muscle training exercise. I tell exercises are good for health. They cost nothing. So and we should start in the in the young age itself. So just like in Delhi, I tell my patient that when you are waiting at the Delhi, at least I do contraction of my abdominal muscle and perineal muscle. So perineal muscles are either you use it or you lose it. That's Abdul Sultan from UK says. So do exercises 15 to 20 minutes twice a day, twice a day, and for 3 months at least we do, and that really helps us. And then drugs usually are not that effective for SUI, but for urge incontinence we use the drugs. devices don't work that well, but there are some bladder drill and biofeedback. I'll just come to that, and then we will come to the surgical operation. So the same thing basically: weight reduction, decreased caffeine, fluid restriction, bladder training, Kegel exercises. Do them. They should be taught how to do it. This makes sense, madam. Have a one basically this physiotherapy person is posted in our ward, so keep one physiotherapy person, train her well. I was in King's College London with Linda Cardozo. Unfortunately, we lost her just few months back, Linda Cardozo. So that she was spending, madam, 45 minutes to 1 hour just on one patient, physiotherapy, and explaining her properly. I was so surprised that how much she has time, but then it is really effective, so that she contacts the right muscle. That is important. And then so there is level 1 evidence that pelvic floor exercises is effective in treating SUI. So at least what we do, madam, at AIMS we have got 3 months waiting list for surgery. So I put the patient in waiting list for surgery for 3 months. During this time, I give her calcium, vitamin D, pelvic floor exercises, bladder training, reduced tea, coffee. I ask her, and after 3 months, I assess the patient again. And at that time, some patients say we are about 40 to 50% relieved. Can we go ahead with the medical treatment? I said, by all means, we are in no hurry to do surgery. So like that, we can give them. So never thrust surgery on them in the first place itself. So let the patient demand surgery. It has been in my experience that, madam, about those patients of mild to moderate, they may, the medical management may work for them for SUI, but usually severe to moderate to severe require surgical treatment. Biofeedback just helps in the same thing only. Vaginal cone, the patient keeps the cones inside the vagina, they are expensive, but the cone tries to come down by gravity, and the pelvic floor muscle tries to contract and retain it, so that's how the muscles grow better. Electric stimulation also same thing, so that she contracts the right muscles, but not really required. These are the various devices people have made it, but unfortunately they don't work that well. Suage arranging, incontinence, this and all. So you can have you can make a device of your own. Most probably it will not work, but you will become immortal, as someone in the morning was saying. No. So then medical management, usually for stress incontinence, it doesn't work that well, but there is only one drug, duloxetine. So sorry for the doses, 20 to 40 only. I mean, I'd never go beyond that. So 20 milligram once a day can go up to 40 milligram. So I tried for 3 months, man, 20 milligram once a day. And ACOG has not yet, FDA has not approved it for this indication yet. But I mean, we can try for 3 months and all, cause little bit of Raynaud. So this thing, but can try it initially. So usually after 3 months, what's seeing that most of the patient of moderate to stress incontinence, severe stress incontinence, they will require surgery. So I'll just highlight, I mean, learn only 2 or 3 techniques. I'll just show you. There is some role of laser and radio frequency, but we don't use them at AIMS because they cost 30 to 40,000 rupees every 6 months. So how many patients can afford that? Though they may have some vaginal rejuvenation, and they may have, to some extent they may have. So I tend to do surgical treatment for them. So I learned, this is the burst corpus suspension. Put the patient in throttling position. Okay, one assistant stands between the 2 thighs. I put a Foley's catheter inside, inflate the bulb to 8 ml, and then my assistant lifts 1 cornice for me. From above, I open the abdomen by transverse 4 to 6 centimeters, but don't open the peritoneal cavity. So work under the pubic symphysis, just little bit lower. And then I don't open the peritoneal cavity, so I work in the cave of urethra. So what will happen? This is like, my finger will be stopped by the catheter, that is urethra. So now catheter is urethra, inflated bulb is bladder neck, and this is bladder, like that. So then my assistant lifts left fornix for me with a sponge holding forceps or finger with a thimble, like that, and I take a deep bite with chlorine stitch, 1 hair, and just hold it, another hair, hold it. Then she comes to the right side of this, I lift it for me, so I could take 1 stitch here, 1 here. So 2 stitches here, 2 on this side. And then I come to the pubic symphysis, like that, you can see that. So about 1.5 to 2 centimeter later to the pubic symphysis, the right pubic ramus, here is the Cooper's ligament. So same stitch with needle, I prick it here, another here on the left side, and the same on the right side. So that means that you can say the left stitch will go the left, right will go the right side. So ultimately I just tie it gently. Okay, no, don't make it too tight. So you can see the colpos suspension means, colpos means vagina, suspension means being suspended. So what had happened basically, because of childbirth trauma, proximal urethra had become had gone down from the pelvis. So we are bringing it back to the pelvis. So that is the scientific basis of the surgery. The results are almost 90 to 95%, and this thing can be done by laparoscopic route also. So it's one of the best operations. And basically, I like in AIMS, I did the tapes also, but those patients who couldn't buy tapes, I would do burst free of cost. In AIMS, it's free of cost. But only thing, keep the patient for 3 to 5 days in the hospital, catheter for 72 hours, and then send. So it's a very strong operation, but 90% success rate and almost 70% long-term success rate. Laparoscopy can also be done. Then came the tapes. They are much easier and simpler operation, started by Unson. So this is the TVT, which is put in the anti-abdominal wall. Like again, put the patient in throttling position. We put the this Foley catheter, and with there is this some instrument in that so that we can manipulate the bladder. Then we put the make a vertical incision on the vaginal mucosa, separate the vaginal mucosa from urethra, do dissection between 2 PVs. Then we put one tape on one side, one on the other side, and put a cystoscope so that we don't puncture it. You can just see it like how it will go. So, but with that, there is 6 to 8% injury of the bladder and urethra. So, it's not a big deal. I mean, even if there is a so cystoscope, where you just withdraw that needle and put it lateral to that. You don't have to do laparotomy. You don't have to take bladder stitches. Just keep the catheter for a few days. But still, 6 to 8% bladder injury rate is not acceptable to me. And as a gynecologist, we are not very happy to do cystoscope. Many times not available. So then, when the tape TOT came, then I immediately switched to the TOT. Again, same thing. Patient puts in lithotic position. Okay, vertical incision 1-2 centimeter on the vaginal mucosa. Separate the vaginal mucosa from urethra. So it's like cystocele repair. Only thing, the dissection is up to inferior pubic ramus. So we do more dissection basically. That is what we do. And and then I take this tape on the right side. You can see there is this guard. We put the guard. Dissection is done up to inferior pubic ramus. So just like here I come and this way. So this is the obturator foramen here. To stay in the medial half upper. If you this is the foramen, so you divide into 4 components. So upper medial. It is I come here. So there are no vessels here. The safest bed. So this is on the right side and that's on the left side. I'll just show in the next slide also. You can see this is how it goes, and ultimately the tape lies like that transversely. And now some of these patients can have groin pain because the tape was going up in lateral. So now the Johnson has come with the abrevio. So in that case there are threads in the lateral part. So the tape is only in the central 4 to 6 centimeter. So it doesn't go up to the basically groin. So it's good, very good results, almost equivalent to tape, and there is no almost negligible risk of urethral and bladder injury in this case. You are going laterally into the obturator foramen. So that's what we do. This you can show it to the post-graduate on a model. You can say this is the obturator foramen we are coming basically. Okay, so this gives very good results and all. So TVT, TOT both are equally good in hands. Only thing TVT causes slightly more complications, so we shifted to TOT. But for intensive filtered extensive, TVT has slightly better results for that. Otherwise, almost equally good. So depends upon what is you are being trained in and all. In good hands, you can see. Only problem is that because these tapes were polypropylene mesh foreign body, so US FDA, I'll just finish in 2-3 minutes, sir. US FDA gave warning, and also then and they're not available in UK. So then we came to these patient's own tissues. So I gave this thesis topic to my postgraduate Mansi. She's become SR and now she got a fellow. So what we do, man, just like on this psychopexy we do. So we open the abdomen, this is the rectus C. So we cut about 8 into 1 to 1.5 centimeter tape. Just cut it from both ends, and then we put 2 prolin stitches on it. And from vaginal mucosa again I make a dissection of 2.5 to 3 centimeter same way, inferior pubic ramus, just like dissection we did, essentially throttling position. And then from above, then again same I do dissection just like birth corpus suspense. So this is the bladder, this is the urethra, this is the catheter in that. So I put a clamp from here, tip of the clamp, and then from below there is a tiny mucosa on it. So my assistant from below give a tiny stab at the neck of it and feed me the this sling basically with prolin. So I take it up. Same way I repeat the process on the right side, so that I avoid injury to the bladder and the urethra. And then we bring it anterior. You can see the tape below, and keep an artery process. We don't make it too tight. And then we bring it, perforate the rectus sheath and bring the anterior to rectus sheath. So in other words, this is a tape like that now. And then the stitches are there. So we tie it, but keep one artery here, one below, so that we don't make it too tight. It's a very strong operation. So it's a patient's own tissue, basically rectus sheath, free of cost. And totally patient, it doesn't cause any mass erosion, and this is the same thing basically, yeah, like that. We ultimately tie it, and that is how it is. Okay, so this was the so we published this study and all, but only thing in this case it goes and so the patient is very obese, previous 2-3 surgeries and all, then taking the tape from abdomen becomes difficult, and again we have to do abdominal route. So then can we go by vaginal route? So TOT, just like we do TOT, can we do that? So we have done that now. But we are taking help of our plastic surgery people. So they come and they take this tensor fascial lata 8 cm to 1.5 cm strip for us with a small stripper. Just a tiny incision they make, and they give a stripper to us. And so then again same thing, we take that 8 centimeter tape, patient's own tensor fascial lata, we put 2 prolin stitches on either side, man. And just we are using so vaginal mucosa stitch same way we do, and then again we feed just like we are going through operator foramen. Now we feed the, instead of patient artificial tape, we are using patient's own tape. So we have got both inside out, outside in. So this rectus fascial lata with 2 prolin stitches on that. so that we put in the eye of the patient, in that of the needle, and then that's all. So this will make like that. You can just see how we are making it. And these are the TOT needle for outside in approach. So you can use outside in or inside out approach both way. So that is how ultimately this you can say, and it came out through the operator foramen. Just like the mesh was coming, so same is coming, and then we just tied there. Or initially I was taking a stitch with the proline, with the vicryl, and so that the tape stays there. But even if the tape, without stitch also you can leave it. The tape will just stay there and it will work. So this is even simpler, and we don't touch the abdominal cavity. So now we have done about 9-10 such cases. In fact, just 2 days back also we did a case. So we are shifting from abdominal route to this route, and gradually we are planning to buy taking our own that stripper, facial lateral stripper. So we won't take the help of our surgery or the plastic surgery colleagues. So that can be done. But till now we are using their help. So it's becoming the giving thesis also. And just to highlight that that thesis I gave. Okay. So this for the postgraduate, Mansi was our JR. So we gave this thesis. You can say it's not that your thesis give a thesis which you just submit for passing your MD exam. So this thesis was published in European Journal of Gynae as a postgraduate. So imagine a PG getting a paper in European Journal of Gynae, and it was appreciated. And then I was invited by Yogi Journal to write a review. So Mansi is there also in that. Autologous facial sling for surgical management of SUI come back. So this is, and these are our other some studies we did on TOT tape also we use. Then others like you can do incontinence sweet index, that's also part of our thesis. Vitamin D levels we did in SUI again. So these are various, and this we just did various urogyney problems in their subsequent management with plant. So just you can do a study in Imphal. In this thing, what is the prevalence of urinary incontinence? So maybe you can all the patient, sir, Dr. Ranjit is sitting here. So like you can give 1-to-1 PG SR or some fellow. So she can study 200 to 300 patient or 500 patient. Ask them every patient coming to gynae, have you got direct question? Have you got urinary complaint? If yes, SUI urgent incontinence like that. So we can say out of 500 patient, like say 40 had some symptoms, and then you can do urodynamic on them. So you can make out that incidence in Imphal was 12%. So and you can compare that in Delhi it was 8 to 9%. So it may be same, it may be more, it may be whatever incidence comes. So we need actually incidences in India in different states. And if they don't publish it, I am editor of a journal, I will publish it. That's a promise. Okay, so thank you. Thank you. So that's it. That's the last episode. So basically I have finished it, and overactive bladder again same thing basically, just like my last slide. For overactive bladder syndrome, urgent incontinence, you can give them drug. So derifenacin 7.5 mg OD for 3 months, or solifenacin 5 mg OD for 3 months. And if the patient has got some problem with the anticholinergic drugs, then you can even give them mirabegrod 25 to 50 mg a day for 3 months. I assess them after 3 months, madam. And then if the patient is happy with that, I can give this drug up to 2 years. After 2 years, by this time they will lose weight. She will do pelvic exercises, and she will reduce tea, coffee fluid intake, and so this she gets much better. So aim is to withdraw drug after 2 years, and then she is okay with the other method. But out of my patients which I after 2 years I stop the drug, give them drug holiday for 3 to 6 months. After 3 to 6 months they come back. In my experience, about 60-70% they are happy without any medication, but 30% when they stop the drug they want to go back on the drug. So we can restart it anytime. So for 4-5 years is not a problem. So like that most patients can be helped. You can really bring joy in their eyes. Man, one of my patients was just last this week, I finished the talk. She was 85 kg. Her real sister was just used to live across the road on the other side. She had not visited her for 5 years. So she had gained weight. Whenever the family was sitting on a cot in the house, family would give her 2 roti at lunch, 2 at dinner time, their duty was over. So they were waiting, to be sad, they were waiting for her to die. She was also waiting for herself to die. And she had stopped going to puja also. This is not written in any books, ma'am. Like, if the ladies have menses, they can't do puja. Same if she leaks urine, she can't do puja. So she said if puja gets bhang. It's not written in any book. So if you deprive an old lady who is leaking from puja also, what is there left in her life, other than waiting to die? So I did the surgery for her. I told her to lose weight. She lost 2-3 kg weight. I did a birth size. I think I did birth for her, and she became all right. She lost 2-3 kg weight. They were twinkling in her eyes. She said, Doctor, I want to lose more weight. Now she goes to her sister every week across the road, or her sister comes to her. So they bitch around about their daughter-in-law, each claiming her daughter-in-law the worst. So let them. That reduces their tension, and also she is happy. She has lost nearly 7-8 kg weight. She is 75 kg now, and she said, Doctor, I want to live longer now. So you can really bring joy in this space. You can do so much for these people, and please, if they may not give you good gifts, like IVF patients or young fetal medicine patients, these elderly patients, but they give you blessings, and these are the blessings which help you. I did a surgery on a patient from Kargil, her same 78-year-old, and when she got okay, she said, I go to Gurudwara, I ask for you, your face comes in front of me, I ask for you from Guruji that, Dr. Sharma should be blessed. And same year I got BC Roy Award. So thank you very much, sir.
Thank you so much, Dr. J.V. Sharma. I think that was an excellent lecture, putting so many things in one small bag, but SUI itself, it can make a whole book. So thank you for your experience regarding the history taking is so much important. But because of the paucity of the time, we will take the questions at the end of all the lectures.
Thank you.
Thank you so much.
Next speaker is Dr. Sudhir Adhikari. He will be speaking on tackling fibroid in pregnancy. So, Dr. Sudhir Adhikari is at present working as professor and head at Nasija Academy of Health Sciences. And personally, he is very close to me, and he is a classmate of my wife, and both of them are working together. And he was president of Bengal Obstetrics and Gynecology Society from 2018 to 19. And he organized as chairperson at the IMS conference in Kolkata in 2019, and IAGA conference also he organized in 2019, joint organizing secretary AICOG 2007 Kolkata, and is recipient of Master Trainer Award, EMOC Training Center at an hospital Kolkata, and he was Master Trainer NSB Comprehensive Abortion Care, and the examiner of undergraduates and postgraduates. And he has many publications, more than 100 in number, and he has attended many national and international conferences, and contributed in many journals. So I present Dr. Sudhir Adhikari. Please proceed.
Good evening. It is almost evening here. So, respected chairpersons and learned audience. So, as you have said, you have heard many things from my teacher. He is my guru, and his wife is my colleague. So, with Imphal, my relation is for last 51 years. I was a student of second batch of RIMS. I joined in 1973. So after that I have worked in Calcutta for more than 35 years, and presently I am working in one hospital in private medical college here. So today my subject is tackling fibroids in pregnancy. The prevalence of fibroids amongst pregnant women ranges from 0.1 to almost 4%. The pregnancy complications in women with fibroids are around 10%. The complications depends upon the types of the fibroid, the size of the fibroid, and its location of the fibroids in the uterus. The complications during pregnancy can arise as a result of effect of pregnancy on fibroids, and also result of effects on fibroid in pregnancy. Thus, obstetric students must be well versed with possible complications in order to outline the most suitable management protocol to bring optimal pregnancy outcomes. The effect of pregnancy on fibroids, it increases in size due to this hypertrophy or hyperplasia of their uterine musculatures. There are degenerations, mostly dead degenerations in pregnancy. There can be torsion in pedunculated fibroids, and there can be infection and polypodal changes in puerperium.
So effect of pregnancy on the size of the fibroid, you can see there are many studies because the estrogen and progesterones, they help in growing the fibroids. I can see a small sac, pregnancy sac with a big fibroid. Similarly, increasing fibroid size with advancing the pregnancy. There are changes, cystic, red, hyaline, then hemorrhagic, calcification, different forms of. Here there is one changes in the fibroid during cesarean section. The cystic degeneration, red degenerations, calcifications. Very rarely they go sarcomatous changes in the fibroid. The effect of fibroid on pregnancy, the whole obstetrics books is there. Starting from the bleeding in early pregnancy, bleeding in late pregnancy, abruptio placenta, placenta previa, hypertension, then intrapartum complication like obstructed labor, then retained placenta, similarly postpartum complications, PPH, retained placenta, and there can be in the fetuses also small upward score with this limb reduction, head deformities in the. I also have found myself there is head deformity due to big fibroid complex in the fetal head. You can see some of the changes in ultrasonography. Even there can be fetal death. You can see here. Management, those are uncomplicated. The cases are assessed up to 37 weeks, complete weeks, and mode of delivery is decided depending on the maternal condition as well as the fetal conditions. In complicated pregnancies like infection with retention of urine in early pregnancy may require repeated catheterization till 14 weeks of gestation and may be aided by digital reposition or pessary insertion. Then complicated pregnancies are, see the complications. And elective LUCS is indicated when fibroid is in the lower segment or cervical fibroids or there is malpresentations or other obstetrical reasons which we are practicing nowadays. In the liver management, fibroid above the presenting part contemplate vaginal delivery and fibroids causing dysfunctional liver or obstruction may call for emergency LUCS. That can be with or without myomectomy. And in postpartum complications, there can be heavy PPH and there can be retained placenta. In postpartum complications, you can see increased need for blood transfusion, there can be subinvolution, postpartum hemorrhage, postpartum sepsis, and wound infection too. And neonatal complications, as I have mentioned already, low birth weight, low upward score, fetal anomalies, and now we come to cesarean myomectomy, depending upon the position, depending upon the expiration of the obstetricians. The cesarean myomectomy also can do during the management of the labor. Traditionally, obstetricians have advocated against myomectomy during cesarean section. It was feared that it may cause uncontrolled hemorrhage and unnecessary hysterectomy. The myomectomy is an often performed surgery, but domain of cesarean myomectomy or myomectomy in gravid state of this remains greatly unexplored because of depreciation of the cesarean myomectomy and myomectomy in gravid uterus. The fear of uncontrolled hemorrhage and may end up in hysterectomy. That was the fear. It was tempting for the adventurous and the sympathetic surgeons to condense the operations for cesarean section and myomectomy into one undertaking, and so to save his patients the ordeal of a second admission in hospital. This kindly and misguided policy we hardly deprecate. That was said by Bonnie long back. The textbook's indications are pedunculated fibroids, subserous fibroid, or fibroids are encountered in the incision line during cesarean section. But scenario has changed based on the evidences and experiences. Uterus in immediate postpartum phase is better adapted physiologically to control hemorrhage than in any other stage in women's life. Uterine fibroids are very common in black African women, and encountering fibroids during section was almost inevitable. The first published related to this thought was inevitable caesarean mammectomy by Ehigma et al. In 1998. There are many studies, you can see, there are many studies in caesarean mammectomy, and our experience, my old experience started from 2005. I did 1023 cases of mammectomy during caesarean section, and 82 were diagnosed internally by ultrasonography, and majority were anterior myomas. There was no statistical blood loss or incidence of postpartum fever. Post-operative time was almost, compared to the others, normal, and postpartum stay also was almost normal with others. Non-required hysterectomy or embolization, the size of the fibroid did not appear to affect the incidence of hemorrhage. There are many techniques used by many authors to control blood loss. The basic 3 steps to reduce the blood loss: intraoperative vasopressin, diluted vasopressin 1 ml in 200 ml of normal saline, and routine use of electrocautery routinely, and dead space obliteration with 5 kil, either 1 or 10. You can see how vasopressin is injected, and electrocautery and proper stitching. Average time taken for LUCS along with the mammectomy was for nearly 1 hour. Average blood loss was nearly 500 ml. This study was almost compared to the other studies conducted by the other authors. And out of this, 72 women had multiple myomas. We removed 9 fibroids from 1 case. In 6 cases, the huge myomas, about 2.3 kg to 3.8 kg, were removed prior to the delivery of the babies. See the multiple fibroids from 1 uterus, pregnant uterus, during my cesarean section. We followed up this for 6 weeks, and those showed uterus was properly involuted. Non-required hysterectomy. And advantages of caesarean mammectomy: avoiding interval mammectomy. It is cost effective because in one surgery we are doing 2 surgeries. The message is clear. What was once thought to be taboo should be now reconsidered. You can see some of the photographs, still photographs, the big fibroid in the margin. We enucleated. See 2 cavities you can see. Big fibroids repaired. You can see multiple fibroids repaired. Big fibroid again. You can see big fibroid, and we are taking out the fibroid and repairing. A very big fibroid, and through the incision in the posterior fibroid, a transcavity approach in posterior fibroid. You can see 2 cavities, one for the primary, one for the this fibroid mass. See uterine cavity. See the dead space after removal of the myoma. This were repaired, and this is the uterus. You can see anterior myoma. Look at it following delivery. It was removed. See big fibroids. So multiple fibroids. You see posterior big fibroid, huge fibroid, just more than the fetal head size. We have injected vasopressin, electrocautery used, and removed the fibroids, and they repaired the uterus. See, this is the structure in the posterior. There was changes, red degeneration. The time has changed. With that, the traditional teachings have modified themselves. Though mammectomy during pregnancy is still not very encouraging, caesarean mammectomy is no more feasible undertaking. In whatever then gravid uterus if we face in during pregnancy, fibroid in pregnancy, for the fear of fetal loss, for the risk of uncontrolled hemorrhage, needing hysterectomy, mammectomy is avoided in gravid uterus. But myoma causing pressure symptoms, abdominal pain, fetal growth restriction or intrauterine abdominal bleeding from torn surfaces, vessels on the torn surfaces might need this operation. See this case, a pregnant uterus with heavy pain transferred from one state to other state, from Tripura to Calcutta. So this was the gravid uterus of 14 weeks. You see, we removed this tumor, nearly 4 kg in piecemeal, but we did not use electrocautery, but if it is used, very low volt. See big chunks. We repaired the uterus, and see this fibroid masses in pieces from a gravid uterus. And the pregnancy continued, and she delivered at term with a healthy baby. This is the baby. The parents came from Tripura. The second case, you can see a gravid uterus. 3 basic principles we need: hydrodissection, low voltage catheterization. Instead of adding vasopressin, we use water only, and judicious death perception. Available case reports describes myomectomies, all of which were performed in the second trimester, ranging from 15 to 25 weeks. In both of my cases, myomas were huge. That there is risk, fear of landing in the amniotic cavity and damaging the pregnancy was always there. In conclusion, with the advent of better anesthesia, availability of blood, with vasopressin as a regular adjuvant in the hands of an experienced surgeon and in a well-equipped tertiary institution, cesarean myomectomy is no longer a fetched job, and even in some instances, myomectomy in gravid uterus also. Nothing is permanent in this wicked world, not even our troubles, which was said by Charlie Chaplin. Thank you. I have got 2 videos, small videos. Kindly play this video.
Thank you, Doctor.
2 small videos. One in a gravid uterus myomectomy, one in during cesarean section. Very small. This is a video of myomectomy in a gravid uterus. You see this big fundal fibroid. She was having severe pain, not related with even all types of analgesics. Just infiltrating of normal saline. The base is gravid uterus. 14 weeks. with severe pain, not relief with all types of analgesics, even sedatives. Continued to full term, then cesarean section was done. The posterior wall, you can see. That is myomectomy during cesarean section. See a big fibroid. This was done in a live workshop in SSKM Hospital, PG Hospital, Kolkata. Live workshop, in a live workshop. So if you stitch from the base, just tearing sutures, you see this whole thing coming together, coming close to each other. The big rod was becoming smaller and smaller, smaller and smaller. I think so fibroid in any wall, if it is in the posterior wall, lateral wall, anterior wall, fundal, there is no problem removing this fibroid from the uterus when doing a cesarean section.
Thank you, Dr. Surya. You have shown a very nice video also. But in the conclusion, that the last word you have given, it should be in the hand of a very experienced person.
Definitely.
And also in a well-equipped hospital. And all of us should not forget that point.
In Bombay ACG, I have presented this.
Thank you.
And everybody appreciate that time. I think after that time, people started doing more myomectomy during cesarean sections.
We'll proceed with the next session.
Thank you, Dr. Adhikari, for that beautiful presentation and videos. I think I have the pleasure to invite Dr. Archana Kumari, who is from Ranchi, and she's the founder secretary of IFS Jharkhand chapter. Incidentally, she was also the organizing secretary of 2022 East Zone Yuva FOGSI. And she is also East Zone coordinator of Quiz Committee of FOGSI 2018 to 23 and FOGSI representative of ROGS. And she was the organizing secretary of 8th annual conference of ROGS. And she has a long teaching experience because at present she is working in RIMS. And I think you are going to talk on a very important topic. Yeah. Cardiomyopathy.
So at the outset, I would like to thank the organizing committee, especially Dr. Pratima, for giving me this opportunity. And I must thank and also acknowledge the chairpersons and the FOGSI dignitaries in the front row, Dr. Madhuri Patel ma'am, Alka Pandey madam, Dr. Basa Mukherjee, Rekha Jha ma'am, Archana Jha ma'am, for the patience for being here with me till the last moment. So the topic is relatively heavy, peripartum cardiomyopathy. So in the next couple of minutes, I'll be discussing about the introduction, the pathogenic factors, clinical presentation, diagnosis, management, and if time is there, I will discuss a case which I recently came across of the peripartum cardiomyopathy. Well, this is a rare cause of heart failure which was described as a distinct clinical entity only in 1930, and previously it wasn't for them. The incidence varies, relatively high in Haiti, Nigeria, less common in Japan. One of the studies from South India depicts the incidence of less than 1 per 1,000 live births. The risk factors are advanced age, multiparity, multiple gestation, black race, and maybe history of preeclampsia, eclampsia, postpartum hypertension is also sometimes associated with peripartum cardiomyopathy. Well, I am not going to go in much detail about the pathogenic factors, but there are androgenic imbalance and altered prolactin processing is definitely playing a role, which may cause endothelial damage and myometrial dysfunction. Other than this, is there any role of genetics? Yes, there are mutations noted in the sarcomeric protein titin, which is called TTN. So this may be associated with peripartum cardiomyopathy. Other factors could be there. Well, normal pregnancy is considered as a hemodynamic cardiovascular stress test, so that an uncomplicated pregnancy is analogous to just completing a normal stress test. But when there is specific genetic or biological susceptibility, peripartum cardiomyopathy may manifest as a not going through that normal stress of the pregnancy. Well, clinical presentation, I already discussed, it presents in the last month of the pregnancy or usually during first month postpartum, and most cases are usually diagnosed, they come as readmission after discharge with severe dyspnea or cough, orthopnea, pedal edema, hemoptysis. So the symptoms are very similar to the other causes of heart failure. And the signs are also like of that heart failure, tachycardia, elevated jugular venous pressure, pedal edema, pulmonary rales. But patients with peripartum cardiomyopathy and ejection fraction of less than 35%, they are at risk of developing left ventricular thrombus as well. Well, the diagnostic criteria I already discussed. That was the 3 diagnostic criteria: heart failure in the last month of the pregnancy or within first 5 months following delivery, ejection fraction less than 45%, and no other causes of heart failure could be found. Well, the diagnostic assessment do involve doing the lab tests like complete blood count, RFT, LFT. Brain natriuretic peptide and pro-BNP can be done as a marker of heart failure. These are theoretical things. We are not doing it regularly. The placental growth factor and FMS like tyrosine kinase receptor and the ratios. Genetic testing, of course, we are not doing in our institute at least. And but most important is to do these investigations, echocardio, the ECG, which is important to rule out the other causes of heart failure. Chest X-ray can also identify the other causes of shortness of breath. And echocardiogram is the main diagnostic modality to quantify the severity as well. Well, cardiac magnetic resonance imaging, we are not doing it routinely, but it has been mentioned in few of the books. So what about the diagnosis? It is of course a diagnosis of exclusion. So we have to exclude other causes of heart failure like pre-existing cardiomyopathy, valvular heart disease, congenital heart disease, myocardial infarction and pulmonary embolism. Now coming to the treatment, the general goal of treatment is same as that of the heart failure. We have to provide symptomatic relief, decrease the pulmonary congestion, preload and afterload optimization, hemodynamic support with inotropes and vasopressors, multidisciplinary team to actually optimize and decide the timing of labor, delivery and postpartum, chronic therapies to improve the long-term outcomes, shared decision making about the contraception, which is very important, and education about the future pregnancy risk. So the acute management is similar to the heart failure as a non-pregnant patient, but some of the medications we have to avoid during pregnancy, which are ACE inhibitors and all the drugs which are contraindicated during pregnancy. So in acute decompensated heart failure, we have to give intravenous inotropic support as well. And mechanical circulatory support devices has also been used in a few of the articles I read. Now one important drug to be discussed here is bromkriptine, or what is the role of the antiprolactin therapy, because prolactin does play a role in the pathogenesis. So there are global differences of opinion about the bromkriptine use in postpartum cardiomyopathy. North America, they are not using it regularly, but 2019 position statement from Heart Failure Association of European Society of Cardiology, they do use bromkriptine and the doses is 2.5 milligram once daily for at least 1 week in uncomplicated cases, but where ejection fraction is less than 25% or when the woman has presented with shock, the dose is 2.5 milligram twice daily for 2 weeks and then tapering it to once daily for 6 weeks. But when bromkriptine is used, there is a risk of thrombus formation. So when we use bromkriptine, we have to use anticoagulation therapy as well. And anticoagulation also given when there is a definite thrombus or whenever there is atrial fibrillation. Long-term management, of course, with appropriate therapy, nearly 60% of patients with peripartum cardiomyopathy achieve normal left ventricular function, that is ejection fraction comes to be more than 50%. So with normal left ventricular function for a period of at least 6 months, then we can taper the stepwise, we can do the stepwise weaning of the heart failure regime, close clinical follow-up for 3 to 4 months and echocardiographic monitoring every 6 months to ensure the stability of left ventricular function. But the prognosis is poor in women who present with low ejection fraction and those who have dilated heart even for 6 months after the initiation of the therapy, and time from onset of the initiation of the therapy also determines the prognosis. Future pregnancy counseling is very, very important in these cases because there is always a risk of recurrence with subsequent pregnancy. I think I asked one of the questions for PGs during prelims round, what is the risk of recurrence in subsequent pregnancy? Well, it is 21%. If women presents with, women left ventricular function improves, and if there is persistent left ventricular dysfunction, it is as high as 40%. So patients with peripartum cardiomyopathy with persistent left ventricular dysfunction or with LVEF less than 50%, or when ejection fraction is less than 25% at the time of diagnosis, should be advised to avoid subsequent pregnancy due to risk of heart failure, progression and death. So they should use a reliable contraception or they should undergo sterilization. Preferably husband might opt for sterilization operation. So although the risk of recurrence appears to be lower in women with peripartum cardiomyopathy who have recovered their left ventricular function, but counseling for the option of avoidance of subsequent pregnancy is required in them as well due to the risk of recurrence of peripartum cardiomyopathy. So, lastly, I would like to discuss one of the cases which we recently come across in our labor room. This patient was actually referred to us from the periphery after cesarean section being done for previous 1 Caesar fetal distress. And their OT note mentioned that during intraoperatively there was extension of the right uterine angle with right-sided broad ligament hematoma, which they managed with right uterine artery ligation and blood transfusion. But when the patient reported to us, he was her general condition was poor. He was in shock, tachycardia, BP 80-50. There was tachypnea, SpO2 was 90%, and chest bilateral fine crepes were there. And what was more important is there was abdominal distension. Despite, after cesarean section, the fundus was 3 fingers above umbilicus, and there was actually some doubt because there was hematoma. So, was there any possibility of hemoperitoneum? So, our resident, they're very good in doing paracentesis. They did paracentesis, and it was a hemoperitoneum. So, decision for re-laparotomy was taken. So, this was the picture of re-laparotomy. There was actually a huge broad ligament hematoma. So, the subtotal hysterectomy was done with massive blood transfusion protocol. The patient was kept in ICU with infusion of inotropic agents. Noradrenaline, vasopressin, dobutamine was given. And this is the chest X-ray and echocardiographic picture, which shows ejection fraction was only 21% and global left ventricular hypokinesia was there. And C was maintaining blood pressure of 90/60 with inotropes. But, and of course, the diagnosis of peripartum cardiomyopathy was made, and we managed the case with the help of the team of cardiologists. She was put on ACE inhibitors, beta blockers, digoxin, all the regime of heart failure. And the good thing was that she improved dramatically, and she was discharged in post-operative day 10, of course, with regular follow-up to come in the gynae OPT as well as cardiology. So, takeaway messages. Development of heart failure in last month of pregnancy or within first 5 months of delivery with left ventricular ejection fraction of less than 45% and absence of other identifiable cause of heart failure, we should think of peripartum cardiomyopathy. The etiologies are known, but the final common pathway includes angiogenic imbalance and altered prolactin processing. It is a diagnosis of exclusion. Echocardiogram is the main diagnostic modality with the left ventricular ejection fraction of less than 45%. Clinical presentation is similar to any new onset systolic heart failure due to cardiomyopathy in non-pregnant women. And the management is similar to the heart failure due to other causes, but here we have to give special attention whether the patient is antepartum, postpartum. So we have to take into account the fetal risk as well. The risk of recurrence in subsequent pregnancy need to be counseled, and therefore the patient has to use effective contraception and sterilization. Patients with peripartum cardiomyopathy with persistent left ventricular dysfunction or left ventricular ejection fraction less than 25% at diagnosis should be advised to avoid subsequent pregnancy. So thank you so much. This Yuva FOGSI brings to my memory of the Yuva FOGSI which we organized last year in 2022 at Ranchi, and of course this was under the able leadership of Dr. Basam Mukherjee. You can see this picture. This was of last Yuva FOGSI. So I couldn't resist putting this picture here because I feel so nostalgic being the organizing secretary of that conference, and of course I owe this to our Vice President, then Vice President Dr. Basam Mukherjee as well. And I do seek your support for Chairperson of the Quiz Committee, which has been my passion. Thank you so much.
Thank you, Dr. Archana. That was a very good presentation. Actually, we are doing a project with Oxford University, on the patient, because we think PPCM is very less. Actually, it is not.
Actually
Because
it
we
is
are
not.
not doing echocardiography.
Yeah.
So all the patients in our college, all the patient who comes with heart failure, we do an echo with a handheld machine, and that is sent by this thing for telemedicine, and the cardiologist gives her opinion. And we have found a lot of cases of PPCM. And thank you bringing that prolactin, that one of the fractions of the prolactin is responsible for PPCM. So the all the speakers, if you have any question to all the speakers, now it is open for that. If you have that much of patience now again asking questions. Okay,
I think,
yeah.
thank you so
Too
much.
much actually.
Because we're already so late. Thank you, chairpersons and all the audience.
So thank you the organizing committee for giving us this opportunity. Beautiful session. Yeah.
Thank you, speakers, and thank you, chairpersons. Now, for the felicitation session, I would like to call on Dr. Saraswati Sanyal to felicitate the first speaker, Dr. J.B. Sharma sir, AIMS, New Delhi. I would like to request Dr. Jitendra Singh sir to felicitate the second speaker, Dr. Sudhir Adhikari sir. Let's give a round of applause. I would like to request Dr. Saraswati Sanyal ma'am to felicitate Dr. Achna Kumari ma'am. Let's give a round of applause for everyone. Thank you, speakers. Thank you, chairpersons. Here, coming to the end of today's scientific session of day 1, we support your dedication to showing knowledge and commend your efforts in making the conference a success. Your passion for ops and gynae is evident, and it has inspired many of us to delve deeper into the subject matter.
Once again, thank you for your invaluable contribution. We look forward to the possibility of collaborating with you again in the future and benefiting from your expertise.
Success is not final and failure is not fatal. It is the courage to continue that counts. This is Dr. Cheryl
and Dr. Bandhishika Sarkar
signing off. Thank you one and all.
We'd like to call all our senior delegates, our faculties to come over stage for a group photo session. Ma'am and sir, please come over stage for a group photo session. We will have a cultural show and a dinner after half an hour. Please take rest for half an hour. Come then. Like this.
Hello.
বুঝে গেছো?